Hello, everyone. Thank you very much for taking time to join us on this first day of the premier virtual African conference on uterine fibroids titled Uterine Fibroids, the Science, the Treatment, and the Myths. I am Lisbeth Korasari, the CEO of Fibroid Foundation Africa, a charitable organization dedicated to breaking the silence and encouraging more discussions on uterine fibroids in Africa. We exist to support the countless women agonizing and bearing the ordeal of fibroids and further engage in awareness creation and educational activities as well as advocacy and research activities. Today, we are profoundly delighted to bring clinicians, researchers, policymakers, advocates, and survivors together on one platform to share their perspective on the uterine fibroid situation across Africa. It will also be a discourse aimed at collaborating and advancing efforts to address the concerns of women with the condition. We will also share ideas on recent research and developments to understand the basic science of the tumor, what they are and what they are not, and the current emerging treatment aimed at improving the total well-being of women living with fibroids. I believe the opportune time for this discussion is now. Though COVID-19 has held the world's attention, shifting focus from all health issues, women continue to endure the symptoms of fibroid, and this situation cannot be overlooked, with literature clearly showing that fibroids are common among women of African descent, with statistics pointing to over 70% of women with the tumor. It is obvious that the African continent is an endemic region. Yet, the paucity of data on fibroid in Africa makes it difficult to support this assertion. It is therefore not surprising that fibroid is not listed as a public health issue on this continent, even though the medical community is very much aware of the gravity of the situation. For example, in one local Catholic hospital in Ghana, about 50 to 60% of OPD cases are fibroid related. That facility alone handles about 16 to 18 mammectomies and hysterectomies each week. Multiply this number by the 52 weeks in a year, and I tell you, the total is staggering. This is just one health facility located in a rural community. We are all aware that fibroid bring untold hardships to its victims, financially, emotionally, destabilizing work life, social life, mental health, to the extent that it robs its victims of their joy and fills them with a sense of hopelessness, especially when they are confronted with fertility issues during marriage. We cannot remain silent whilst our dear mothers, sisters, aunties, grandmas, especially those in unserved communities, suffer unnecessarily because of the stigma and shame associated with some of the symptoms of fibroids. As the world moves towards universal health coverage, obviously, the issue of fibroids must be tackled with some aggression to erode the inequalities in seeking treatment. If we all appreciate the importance of the uterus and, for that matter, the womb as a vital organ in human existence, then the issue of fibroids should be at the forefront of every health discussion. It is therefore our collective expectation that this conference will provoke a wider discussion on the issue and set the pace to discover homegrown interventions to drive a comprehensive strategy that will bring hope to women with fibroids, improve their health in terms of management of the condition, treatment, service delivery, and even support. On behalf of the Board of Directors of Fibroid Foundation Africa, I wish to acknowledge and thank our sponsors, Stigovet, partnering institutions such as the University of Chicago, and our speakers for all their efforts in making this conference possible. Dr. Phyllis Lippert of Campion Fund, who welcomed the idea of having this conference, and Lillian Prince of Al-Handi's research team. I wish to say a big thank you to you. I also say a big thank you to Sharon Clark of Campion Fund and Emily Harefield of Duke University, and our producer, Taylor Price of Freedom Films. Once again, you are all welcome to this conference. Thank you. I hope you have a nice session. Thank you.
Good morning and welcome to everyone to this very interesting conference on uterine fibroids in the African region. I'm Dr. Trifoni Nkurunziza. I work for the World Health Organization, the regional office for Africa, based in Brazzaville, Congo. And I'm the team lead for the reproductive, maternal health, and healthy aging in the cluster of universal health coverage and life course. I'm very pleased to do this presentation today on the uterine fibroids in the African region. As you may know, the uterine fibroids are the common benign solid tumors in the African region. They are very frequent, from 20 to 40% in women of childbearing age. And the prevalence of fibroids is 3 to 9 times greater in African women, as you can see on this map. This makes the issue a very significant health issue for many women in the African region. The uterine fibroids are the first etiology of uterine mysis. They are the first operative indication for planned gynecological interventions, and they are the first operative indication for hysterectomy. In terms of risk factors for developing uterine fibroids, there are many different risk factors that have been associated with the development of uterine fibroids, including biological, demographic, reproductive, and lifestyle factors. Although over 30 broad categories of risk factors for uterine fibroids have been examined across various studies, Black race is the only factor that is shown consistently to be associated with an increased risk of uterine fibroids. Other factors include age, family, low parity time, genetic mutation, obesity, vitamin D deficiency, etc. Age, for example, was found to increase the risk of uterine fibroids by up to approximately tenfold, which is very high. It's shown that parity is protective, as well as the use of both oral and injectable contraceptives that are associated with reduced risk. What are the clinical signs that we find in the African region? When uterine fibroids are symptomatic, which can go to 10 up to 20% of cases, uterine fibroids can manifest themselves in 3 major problems. Women can present heavy bleeding that can lead to anemia. The other important problem is manifestation, I would say, is pelvic pressure. It can be pain, but it can also be infertility, which is really, those are horrific consequences of uterine fibroids in the African region. There are other clinical manifestations, I would say rather clinical particularities in the African region. The uterine fibroids are found very, very large, as you can see on that photo. And then they're manifesting in young women. The photo is showing a 32-year-old which was operated in Burkina Faso in 2017. You can see the number and the size of the fibroids. It's very impressive. It's very causing issues, especially the pain, as we said, the heavy bleeding, but the equally important is the infertility associated with the uterine fibroids. What are the main issues and challenges that African women face? First of all, due to lack of knowledge, but also lack of access to care and late presentation, many African women suffer greater morbidity and mortality, oftentimes higher rate of mortality from fibroid diseases. Because there is delayed diagnosis and management, and some of the reasons that causing delay diagnosis and management include the social representation of the disease itself. There are this ignorance of treatment by patients. They can have fear of the intervention. Sometimes they lack financial means to afford the interventions, or they can go also to traditional medicine to try to get the uterine fibroids, or rather the mass being treated at this place. What we think for the treatment of uterine fibroids should really have three main goals. The treatment need to correct the disorders caused by the uterine fibroids. The second goal, which is very important, is promote fertility if necessary, and also improving the quality of life of women suffering from uterine fibroids. In conclusion, what we can say is that the uterine fibroids are the most common benign pelvic tumor. They are very frequent in Black women. They have big consequences because of delayed treatment and diagnosis. We note family predispositions. And then there is need really to insist on education and increased awareness on the uterine fibroids, because this can improve not only the quality of life, but also remove the negative social stigma associated with the diseases, and it can reduce mortality, morbidity and mortality rate in the African region. As I said earlier, the selected treatment should be directed towards an improvement in symptomatology and quality of life. What do we need to do? Of course, the treatment of women with uterine leiomyoma must be individualized, must be people-centered. It has to be based on symptomatology, the size and the location of the fibroid, the age, the need and desire of the patient to preserve fertility of the uterus. Many remain unknown in terms of uterine fibroid disease in sub-Saharan Africa. There is need of research to quantify the extent and the burden of uterine fibroids in the region, especially looking at the impact of uterine fibroids on women's reproductive health and general well-being, but also the costs and the availability of treatment. It is important that the reproductive health policies and guidelines be revised to include the uterine fibroid prevention and management. This is what I can present on this issue. That is a big issue for women in Africa in terms of quality of life, in terms of morbidity, but also in terms of mortality. I want to thank you for your attention. And then I have added also my name and the email address if one need to reach to me. And I thank you very much.
I am a ready. I'm a banker. My experience with fibroid has not been easy.
My friend is Francis Kapojo. Maybe 53 years. Me a choba.
Bacha medin Rebecca. Na mafa nyama bebree mu. Nyama bebree na me fa bi ni say fibroid. Fibroid ya body pa. To me say nyama ama maye nyama bebree mo 27 years. Ena benya saya bi ama mafa nyama bebree.
Fibroid is something difficult when a woman is experiencing it. You know, fibroid, because during my time, during that experience, you know, it's really disorganized my life. I wasn't happy. You know, the pains alone, I was bleeding. You know, I was unhappy. And as a banker, it's really affected my job and the customers. You know, I wasn't giving them my best to them. So it's my prayer that my sisters and mothers who are going through this problem, there should be a medical solution rather than the surgery, because the surgery is very expensive. And I know most of my mothers and sisters cannot afford. So there should be a medical solution to them.
Yes, I know. Emma ejuma no kura mi ntumi enko. Moja no tumi saa. Ntumi nko ejuma. Ntumi da ho saa kosi se. Moja no de efiase atumi no ache. Ntimi bre. Anso ni nyina kura mi di koba. Abedru baabi no na mi ntumi bi o kura. Eho na mi ko hu nurse ni no na o ka kire mi se mi ko hospital. Timi call hospital na doctor tram scanner o ka kire mi se ade no ye fibroid. Timi na anti hospital sa hospital no ko mu no na ye ka kire mi se this ye yi mami. Timi ko hu Fibroid Foundation Africa for omuna omobuwa mi na ye koye mami. Ti me amika ni se ade no de eya wo nti ye se ni amu Fibroid Foundation for ye no ma omu bre sa bre omu wo sa bre no mu mpa cho ni ye nyina ye nka mbom na ye bua omu a eye omu sa na omu ntumi mfiri oha no mu.
Hello, everyone. Welcome to the premier Uterine Fibroid Africa Virtual Conference. The science, the treatments, the myths. My name is Davison Mnodawafa. I am pleased to bring to you greetings from the city of Bweru, Zimbabwe. I will serve as your moderator for the conference. Over the next 2 days, you will hear from clinicians, researchers across the African continent, the United States, and Europe, who have dedicated their lives to the well-being of women and recognize the toll that uterine fibroids takes on our communities. Please refer to the conference booklet for full biographies as I will now briefly introduce each presenter. I would like to introduce Dr. Chris Opuk Fofi, who is a consultant obstetrician, gynecologist, and head of Safe Motherhood Program at the Ghana Health Service.
Hello, good day. I'm Dr. Chris Opuk Fofi from Family Health Division of the Ghana Health Service. I'm here this day to share with you a presentation on the overview of uterine fibroids in Ghana. As a quick outline to the presentation, outline of my presentation, I will start with you with introduction. We'll look at admissions and surgeries nationwide, some risk factors, clinical presentation, major hindrances to management, then policy implications, and then we move to the conclusions. Now, as introduction, I'll say uterine fibroids are the commonest benign gynecological tumors in premenopausal women in Ghana. For the past 5 years, they feature in the top 10 causes of admission in most of the Ghana Health Service facilities. And the leading indication for gynecological surgeries nationwide as well, responsible for quite a high number, above 1,600 surgeries that were reported in the year 2020, according to the Ghana Health Service, which in itself is an underestimation because that doesn't include most of the surgeries done in the private facilities. In the 6 months review from Kolegu Teaching Hospital, which happens to be the premier hospital in Ghana, there was a reported case of steady where about 26% of all the cases that were noted appear to be from uterine fibroid, that is gynecological admissions. So going further, I walk you through the admissions. This is a map of Ghana showing the different regions, and you could see the facilities where surgeries for uterine fibroid do really occur. And these are district hospitals and above, regional hospitals, teaching hospitals, and then furthermore, some private facilities that do quite a number of cases. So in the center, you could see the deep color area. This is precisely the Ashanti region, which is like the second largest city in Ghana, that is Kumasi precisely, and we have just a collection of high volume facilities that perform uterine fibroid surgery. And also we're looking around the coastline, areas around Accra. These are areas where we tend to have more facilities. In contrast, in the northern sector, we tend to have less facilities that do surgery. And also we'll look at how the distribution of uterine fibroid cases tend to be a little bit lower in such areas. From here, looking at the risk factors and how they play out in Ghana, first we start with the age. Age is known worldwide to be associated with uterine fibroid, especially the extreme towards the perimenopausal age, and that pattern is seen in Ghana as well, though we tend to see some very young people in their 20s also appearing with very huge uterine fibroid. So obesity is another factor that has been noted, and we know that where we tend to have more obese people, and that in the previous map, you could see all areas around the coast in the Accra area, Accra Plains. These are areas where obesity generally is a little bit higher than the other half of the country. And these are areas where we tend to have by far more cases of uterine fibroid. All right. There's also this thinking that in such urban areas, there is a relationship with the sedentary lifestyle or affluence, and therefore we tend to have obesity with all these factors coming together. And next, nulliparity is has long been related with uterine fibroid, where we also think that the more women deliver parity many times, then it tends to be a bit protective. But towards these days, what we tend to see is many women tend to postpone their childbirth, pursuing education educational excellence, and as a result, they decide to have children at a later age towards their 40s. And in such women, we tend to see very high rates of uterine fibroid in them. Family history is another important thing, and it's not uncommon at all to see families where 3 children, 4 siblings, all of them going through situations or surgery for uterine fibroid. So that relationship has been established. High blood pressure is one of the factors that we've noted. Many women, however, it's not entirely clear whether it's because the women are nearing the 40s, and therefore naturally the incidence of uterine fibroid tend to be higher, the same as high blood pressure. So there is a bit of work that needs to be done to clarify this, especially in our country. Then late age of menopause is another factor that we've noted that, yes, quite a number of women past the 45 years that usually we expect and go beyond and tend to have manifestations from uterine fibroid, especially bleeding, and that is not uncommon at all. So these are, in short, some of the factors that we can talk about. Then we go further to look at the clinical presentations. Yes, uterine fibroid present in diverse ways. In our environment, the common presentation tend to be with bleeding. Many women might go a long period not knowing at all that they have uterine fibroid until they begin to get abnormal uterine bleeding. And some could be severe enough to cause significant anemia and other complications that can ensue as a result of that. The abdominal mass is also another, because they might not know, clients might not know they have fibroid. Fibroid tend to grow until they leave the pelvic space and get into the abdomen, so they can get very big. An example is the picture you see there, which is quite huge, and it's not unusual at all for any gynecologist who has practiced for a few years to have handled very huge uterine fibroid. And this really tend to offer a lot of challenge when it comes to deciding for myectomy or hysterectomy, which we will mention further later. Yes, pelvic pain and issues to do with, especially with menstrual disturbances are also quite common, and they could be the first presentation that we see. Infertility, subfertility is another associated factor. Many women, when they are not having children, will come looking for any issues to do with fibroid, and that is the first time during the evaluation that we discover that, yes, they've been fibroid either within the wall or endometrial cavity. The pressure symptoms are another of them that tend to also exist, because once you get very big size tumors, they could have compression at the level of bladder with all manifestations that we know about, and also to the rectum, constipation, and all related, that sort of thing. Then in some cases, they are discovered for the first time during pregnancy, and some it's not unusual to see issues with early pregnancy loss, also having postpartum hemorrhage as a result of uterus not from the fibroid. So that is another. It's important to look at some of the major hindrances to the management of uterine fibroid in Ghana. And the first I want to highlight is the high case burden. This is so important because we have by far more uterine fibroid cases than the health system is ready to handle at any given time. As a result, we tend to have very long queues, very long waiting times, because another aggravating factor is that there are limited skilled people. Because the demand is high, so many people without the best form of training tend to veer into the area of trying to manage fibroid surgically, and that on its own causes some troubles at the time, because some fibroids are quite huge, or have their location might require some level of expertise, which such surgeons or young people might not have at all, yet they go into them because we don't have strict regulation restricting the use among doctors. So it's also important to mention that late presentation as a result of all the factors I've mentioned has become very rampant. So tumors tend to grow to the largest extent, making surgery a little bit more difficult for practitioners whenever they meet them. And why do they wait so long? Among other factors that we can identify is our competition from spiritual remedies with unsubstantiated claims. Many people will start their fibroid journey with going to seek spiritual assistance with their pastors, going for prayers. Some will also go for herbal preparations, remedies that they take for long periods before, when all that fails, before they consider going to the hospital to consider surgical procedure. So these are some of the issues. But there are also very important morbidities like severe anemia, hypertension, diabetes that tend to also come in to interfere in the process of the management or treatment. At the time, some clients might not qualify entirely unless some preparation is done, some treatment need to be put in place before they could qualify. Then it's important to mention the prohibitive cost of hormonal treatment. In some cases, due to the sizes, you might want to combine hormones with surgery, but these tend to be by far above the average purchasing power of the Ghanaian. And that's reserved for very few people who can really afford it. The low national health insurance reimbursement package is another factor that is hindering management most of the time. And that is because health insurance pay an amount which is by far below what most facilities would consider to be the right reimbursement. As a result, clients will be forced to top up or effect some level of payment for some co-payment mechanism, which on its own tend to be a little bit high for quite a number of our clients, and therefore they want to spend time to save more money or wait for the best moment before they could consider some of the surgical interventions within our facilities. So we want to look at some of the policy considerations. And here we're looking at the Ghana's Universal Health Coverage Roadmap. It has a clear vision that states that all people in Ghana should have what? Timely access to high quality health services, irrespective of the ability to pay at the point of use. That is incredible. We're saying that all women should have timely access. So the waiting times we are seeing now in the hospital is something that we are working seriously to deal with. That shouldn't happen. We're looking at women being able to have the highest standard of care possible. That will include all the advanced technologies that are available, not just the surgical open laparotomy that is routinely prescribed for virtually all clients, but to be able to expose the Ghanaian population to all the advances of technology, the best care, the best standard of everything, because we believe that the people of Ghana also deserve that type of care. And all that should be done in the confines of an atmosphere where money or cost shouldn't be a hindrance. In other words, if they have money or not, that shouldn't be the issue. For me, for now, that is a huge challenge because financial barrier is still a major problem, and more effort needs to be put in place to deal with that. So we're also talking about the objective number 2 of the Universal Health Coverage Roadmap, which says aims at what? To reduce unnecessary maternal, adolescent, and child mortality and disabilities. We know clearly that uterine fibroid causes a lot of some mortality, but mainly the disabilities that we talk about due to the very high rates of hysterectomies that are done for even young people. In a study that was done in Kolebu in the early around the 2005 thereabout, out of all the hysterectomies that were done, that is unplanned hysterectomies that were done, that is 36 of them in total in a case study, only 3 of them, just 3 of them were planned. All the rest were not planned. In other words, these were nulliparous women who were going in for myomectomy, and due to 1 or 2 constraints during the surgery, hysterectomies had to be done. The story today in Ghana shouldn't be much different from that. On a daily basis, we see quite a number of young people with very huge fibroid, which the only alternative that doctors offer them is to perform hysterectomy. And that is significant disability, because that changes their lifestyle, their dream, aspiration, and a lot of other social dimensions need to be considered in such a situation. So still on the policy considerations, we're looking at what are some of the major things that we can do at the governmental level. We're saying that it would be good to be able to streamline herbal treatments for fibroid. So people are free to advertise the herbal preparations and make all types of claims that might not be entirely substantiated. There should be a way for policymakers to streamline this area and find ways to get improve herbal preparations and get the best of them that have been proven to work, so that they can be added to the arsenal of treatment available. There should be a way to increase the health insurance reimbursement to an amount that is commensurate with the work that is done for clients that come with uterine fibroid. I mean, something that will motivate the private facilities to be able to do by far more cases to reduce the load that we have. Then there should be a way, we're talking about how to encourage and promote local research. There's so much, so many cases of uterine fibroid attended to in the country, but not much of it has been documented. And a good way is to promote local research and get people to come in to look at all the factors that influence it and what can be done to improve the care in Ghana. Still talking about, sorry about that. Still talking about the implications or policy considerations, we're looking at the health sector level. Still quite a number of things can be done, and which are some of them. We're talking about to broaden treatment options to include novel techniques or technology. Here we're talking about laparoscopic surgery, embolization, focused ultrasound, on all new models of managing fibroid that are available. I think the people of Ghana deserve it, and we should make an attempt to include them in the routine management plan that we have in the country. Also, to be able to develop programs for early detection and prompt management. For now, women are managed only if they are able to suspect they have any of the major signs and symptoms and come to facilities. Yet, if we have a design program, we'll be able to catch them first, go through the process of educating the populace to know the signs to watch for, and be able to catch most of them much earlier before they become so big. Then to improve data capture. In the first slide, I mentioned that the figures that we put there don't appear to be the exact figures that we expect, because we're doing by far more, and on the national network, not all facilities are reported. So we're thinking about a way where we can capture the data the best way possible, analyze it, and be able to use that important data to influence policy and get people to understand about the contribution or the problems that we're getting from uterine fibroid, so that we could make some necessary action, right? So here I intend to provide some few specific recommendations, and which are some of them. We talk about how to increase public awareness on uterine fibroid through health promotion. We have a health promotion division, especially with the Ghana Health Service, and sorry, and we hope that that can lead in that process to create that level of awareness that will guide most of our women to be able to know what is expected of them, and also be able to seek for second opinion for most of the surgeries when they are proposed to them. We're talking about to improve the research environment, encourage young people into research facilities, organization to look for good information to guide decision, and also, why not, veer into treatment modalities, new ways. With all that, research is needed. And one way to encourage that is to give research grants to some scholars, to institutions, the College of Surgeons and Physicians, so that many more people can go into that area, and that will be helpful. If we want most of our private facilities to be able to go in for novel technology, then one way is to grant tax holidays. Since most of these tend to be quite expensive for the public sector to bear, another way is to encourage the private sector to lead in that direction. And by so doing, I'm talking about strengthening public-private partnership so that the backlog of cases can be addressed, and also the quality standard of care that women with fibroid receive can be improved to the best level possible in Ghana. So, in conclusion, I would say that uterine fibroids are very common in Ghana, yet very little is published. Women spend considerable time and money looking for quality fibroid treatment, which unfortunately not all of them tend to get what they intend looking for. So it is time for us to focus more on research so that we can, in a meaningful way, improve care that we provide to our women. On this note, I say thank you very much.
Thank you, Dr. Opoku-Fofi. Now I would like to introduce Dr. Prosper Igobeli, an obstetrician and gynecologist with over 45 years of experience in the medical field, caring for women in Nigeria and the United States.
Good morning, everybody. In this conference, which is so well timed, and it is all about the burden of uterine fibroids in Sub-Saharan Africa, and definitely a call for collaboration. So I'm happy that the international community has taken interest in this phenomenon that has been probably overlooked over decades. Fibroid is a big problem in Sub-Saharan Africa among women of all ages. And some women with fibroids suffer from complications of it and die from the disease even without seeing a doctor. The magnitude of the problem calls for international collaboration, and definitely every effort should be geared towards finding ways of teaming up with other parts of the civilized world to address the scourge of this disease among African sub-Saharan women. Uterine fibroids, otherwise known as uterine leiomyoma, are the most common benign tumors found in reproductive age women of all ages, and may affect up to 70% of all women by the time they attain menopause. The greatest burden of this condition impacts Black women, occurring at least 3 to 4 times in them more than in other races. It is estimated that 70 to 80% of Black women will harbor fibroid over their entire lives. Span. A lot of risk factors may be attributed to fibroid formation. And among these, people have postulated genetic implications in Lyme development. And a lot of published data for this to support this, including the current investigation of MET12 and interacting proteins as a possible factor in fibroid formation. So race, as we already said, may be a factor. Ethnicity may be a factor. Vitamin D deficiency status may also be contributory. Definitely age will be a factor to be considered. And obesity, body mass index, then parity, and hormone status of the woman. The kind of life people also live, and early life adverse environmental exposures are all possible and researched risk factors for fibroid formation. Barriers and challenges faced by sub-Saharan women suffering from the disease include but are not limited to inadequate access to healthcare facilities, lack of available well-trained providers, and procedure centers where they can easily manage fibroids. Poor quality of services when such services even become available. Lack of equipment to further investigate and mitigate the fibroid situation. So there's infrastructure problems that hinder proper access to care. Then we talk about economic empowerment, affordability. So lack of economic empowerment, no health insurance to take care of the bills. So a lot of women afflicted with disease are left to fend for themselves out of pocket, coupled with the poor nutritional status found in many sub-Saharan African nations. Then, the cultural implications of stigmatization. If somebody has fibroid, one, they may be looked upon as witchcrafts or something else or things like that. So the women suffering from uterine fibroids really have problems, especially in sub-Saharan Africa, lack of accessibility, lack of empowerment, economic empowerment, and then cultural stigmatization. How do we determine how to manage fibroids? Whether or not the patient is having symptoms from the fibroid is a major factor to determine. Desire for fertility. A lot of women with fibroids are in their reproductive age group. And we know that 3 to 5% of these women have really a direct impact of fibroid in them that prevent them from getting a successful pregnancy to term. Then the size of the fibroids. The bigger the fibroids, the more comorbid the conditions for the patient. Locations of the fibroids also matter. Fibroids may be endometrium, in the endometrial cavity, may be intramural, or maybe where outside the uterus, as noted. The age of the woman and how close to her menopause the woman is determines the kind of management you offer her. The woman's general state of health and severity of symptoms definitely has a part to play. Will the patient likely return for follow-up visits following her initial evaluation and management is a question that requires to be addressed. Many African women do not return for management when they are seen first and they are taken care of. So there's no mechanism to follow up majority of the women treated for fibroid and the outcome down the road. And that hinders research and data collection. The initial evaluation and diagnosis hinges on several factors. One is clinical examination, whereby you see and palpate the patient. And this is where the majority of patients with fibroids present in Africa. So they have already have an advanced stage. If you can palpate a fibroid, that fibroid is already advanced. And that leads to what we call late presentation for the evaluation. And late presentation has a direct impact upon success of how this problem is managed in our environment. Then other areas of investigation that are simple and easily accessible are ultrasonography and saline infusion sonography and hysterosalpingography. These are inexpensive and relatively non-invasive procedures that will help the clinician diagnose majority of fibroids in low resource settings like ours in the sub-Saharan region. These parameters of investigation are available in most healthcare providers. Private physicians and to the patients, and we help enhance patient management. You can see in this particular slide the clinical evaluation and diagnosis of fibroid is very, very easy. You can see that even by just mere overlooking, you know that these patients are laden with burdens of fibroids. So how do we manage fibroids? In Africa and probably in the world, first of all, we look at the burden of the disease. Some fibroids need not be managed at all, but be followed because they're not presenting any signs, no symptoms, and no inconvenience to the patient. Some fibroids can be managed with some medications. These medications can include how to manage symptoms like pain associated with the fibroids. You can use NSAID, non-steroidal anti-inflammatory medications, and acetaminophen for pain. Then for excessive bleeding, we will consider iron supplementation to prevent anemia, or we can use low-dose birth control pills, which can help control heavy bleeding, like progesterone-like injections, Depo-Provera. We can also insert intrauterine devices that contain small amounts of progestin-like medications to help to control heavy bleeding. Then we come to more sophisticated, more expensive medications like gonadotropin-releasing hormones agonists. Sometimes they are used before surgery to make fibroids shrink and easier to remove. But these fibroids, as I said, can become expensive and out of reach for the common poor woman or family. And then you can use also what we call vitamin D, has been investigated to be beneficial for fibroid prevention, especially in the early onset of it and in the early age woman between the ages of 18 and 30. It can become very beneficial, but more research is needed for this. But it is a very inexpensive, easily available, and affordable pro-fertility medication with very little or no side effects. If daily treatment is initiated early, before the age of 20, this intervention may reduce the burden of fibroid and will have significant impact on the quality of life with those who have the disease. Then we come to another level of management, which now may involve bringing the woman into the hospital and arranging for surgery. And in Africa, hysterectomy for fibroid is rarely performed. Most women would prefer myomectomy because of their cultural beliefs that they need a womb when they come back to life the next time. So other interventions like endometrial ablation, myolysis, uterine fibroid embolization can also be employed. But these are actually, all these need good centers with good expertise, good doctors, good equipments, and environment to make a successful surgery for management of uterine fibroids. A lot of the current areas in the villages where surgeries are performed, they are under-equipped and not fully supervised by well-trained providers to provide these services for optimal outcome of fibroid surgery. So that becomes a problem for us. Then, because of this, there are a lot of complications coming out of fibroid management. First, because of late presentation, and depending on the size and locations, some women with fibroid may experience amenorrhagia, which commonly leads to severe anemia, and if not properly managed, leads to shock and death. And of course, pelvic pain and pressure, and subfertility and miscarriages. All these are complications of having fibroid and not managing fibroid properly. And when you have such co-management, there's risk of hemorrhage, intraoperative hemorrhage, intraoperative shock and death, and post-operative fever and wound adhesions and infections. And that may also lead to protracted hospitalizations. Severe consequences include destruction of endometrium during fibroid enucleation, especially when uterine fibroids are multiple in number and bulky, causing amenorrhea and iatrogenic infertility if incidentally or accidentally the endometrium is removed during such operations. So, what is the import of all this for us in this conference? And how do we look for future directions? It is established that fibroid is a big problem among women in sub-Saharan Africa. How do we approach to mitigate these so that these women can have a better lifestyle and a better outcome for the management of their conditions? Education and advocacy are the key. A lot of women in Africa are not yet educated. They live in villages, not accessible to common ideals of modern technology, and to reach them becomes extremely difficult. They need to be reached through advocacy. They need to be reached through education and empower them to understand that early presentation when they have fibroid is the key to good recovery from the disease and good outcome. Then we move to the international community, where I think that collaboration is a key factor in not only solving the problem or help to mitigate the problem of fibroid, but also to help in research and funding. There are a lot of things the world can do together. Fibroid is not limited to African continent, it's all over the world. And if we can study the fibroids in all the continents, know how the biology of fibroid exists, I think it will give us an insight how to reach out to the people, give them correct information, good facts about their conditions, and it will lend some knowledge and data gathering in the research international community. But the fundamental issue is funding. And definitely, we look to the well-strategized economies, the Western world, to provide the funding base for the research. And then, with collaboration and research and funding, I believe that fibroid, its formation, its management, and reduction in the numbers will be effectively contained. And I rest my case. Thank you for it. Thank you.
Thank you, Dr. Igobrioli. Now joining us from Egypt is Dr. Issam Othaman, an obstetrician and gynecologist who has been a faculty staff member of the OBGYN department at Aswit University since 2009.
Hi, everyone. My name is Issam Othman. I'm a professor of obstetrics and gynecology in the University of Asyut in Egypt. I will have the pleasure and honor today of talking to you about uterine fibroids, the Egyptian perspective. So throughout the next 10 or 15 minutes, we'll be describing the Egyptian perspectives on the statistics on uterine fibroids, specifically the prevalence of the disease, the options available for treatment in Egypt for the uterine fibroids, and the patient support groups or advocacy or patient education in Egypt, and policy, what we have and what we hope to have in the future, and the research, what has been done, and what we are striving to achieve. So I have no conflict of interest related to anything in this presentation. So speaking about the prevalence of uterine fibroids in Egypt, unfortunately, I could not find a study speaking or describing specifically the prevalence of those benign neoplasms in Egypt. However, I looked into this meta-analysis, which was describing the prevalence of common gynecological conditions in the Middle East and the neighboring countries to Egypt. As you know, Egypt is located in the north of Africa and in the center of the Middle East. It's described best as North African and Middle East region. So for neighboring countries, as you can see here, for women admitted for hysterectomy, for any gynecological indication, there is a prevalence of nearly 30% of uterine fibroids in those women. But if you look at women who are admitted to do hysterectomy for the bleeding, for the abdominal bleeding particularly, you will find nearly double this number, nearly 60% of women with uterine bleeding who are admitted to do hysterectomy are doing so because of uterine fibroids. Then I thought of just zooming in a little bit. So I looked into the statistics of my own university and my own hospital. I work at the Women's Health Hospital affiliated with the University of Asyut in the south of Egypt. We are a tertiary care, a university affiliated hospitals. We are a tertiary care center. We are treating and training people from most of the south of the country, a huge population. So as an example, for the year 2021, we had 122 hysterectomies, of which 43 were done for the uterine fibroids. So this is around 35.3%. So nearly 1/3 of all hysterectomies we did in 1 year were because of uterine fibroids, and all other gynecological indications, including even malignancies, mount to the other 2/3, a huge burden of the disease. And as you can see, this number is very comparable to the numbers of the countries in the nearby region. In addition, we had also 48 myomectomies done within the same year. About the treatment options available in Egypt, this figure shows the general treatment outline of the treatment options available for uterine fibroids, the medical management, the interventional radiology, and the surgical treatment. So for the medical management, the non-steroidal anti-inflammatory drugs and the tranexamic acid represent the backbone of the medical treatment, and they are readily available in most countries. They are cheap. They are offered to patients, and Egypt is no exception. They are available and prescribed in Egypt as well. Then combined hormonal contraceptives and progestins, these are available as well. They are being prescribed, and they are easy to get by the patients and affordable. The selective progesterone receptor modulators, these have not been introduced to the Egyptian market. They have been introduced into Europe, and then they are suspended for investigating cases of liver injury. However, they have never been introduced into the Egyptian market. They are not available here at all. Antiprogestins like the mifepristone, they are not available even, or they are not available either. And these do not add to the armamentarium gynecologists had for the treatment of uterine fibroids. GnRH agonists, these are available. These are readily available in the Egyptian market. However, their use is limited by the high cost and by the associated side effects. So these do not really come on the first seats in the prescription for the treatment of bleeding or reducing the uterine fibroid size as medical treatment for women in Egypt. The GnRH antagonists, the oral antagonists, the oral GnRH antagonists, which have been recently introduced, the elagolix and the more recent application of the rilugolix, these have not been introduced to the Egyptian market. They are not available. Iron supplementation, sure, are available. They are cheap. They are prescribed readily. But a limitation for their use is that not all gynecologists are aware that they need to treat the associated anemia. So as a gynecologist, you are being attracted to the fact that the woman has heavy menstrual bleeding, so you need to treat that. But please, it's your job, it's your duty, it's your completion of care is to treat women with iron supplementation to treat the associated anemia. So they are available, but not all clinicians or not all gynecologists are aware that they are the ones who should prescribe it to treat the anemia associated with heavy menstrual bleeding with fibroids. Aromatase inhibitors, they are available in Egypt and they are being prescribed. So moving to the procedural interventions or the interventional radiologies. The uterine artery embolization is one of the options that are available to women with fibroids in Egypt. However, their use is limited by the cost and by the fact that few or not too many centers offer them. And subsequently, the expertise, the radiologist expertise are kind of limited with that. So we end up having few centers offering this kind of technology with a good experience. And for a country above 100 million population, you need a lot of centers to offer one particular service to be really used readily by the patients. The MRI-focused ultrasound surgery, this has recently been introduced to Egypt, but again, very high cost, very few centers, and probably the learning curve is just starting with those equipment or with those machines. So I think we still are kind of building up the experience for treating fibroids with those technologies. For the surgical options, myomectomy and hysterectomy, they are available, they are readily offered by surgeons and more or less being acceptable by patients. However, if we analyze the route by which those surgeries are done, we will find that the predominant route is the open surgery, the laparotomy, because the hysteroscopy or laparoscopy, even robotics, these are kind of available and used, but they are on a much limited scale compared to the open surgery. A reason is the cost, the availability of equipment, and the availability and maintenance of equipment, and the availability of the trained surgeons who can work with those equipment. The radiofrequency ablation, this is not an option in Egypt, it's not available. The endometrial ablation, yes, this is available and this is being used by gynecologists in Egypt. So moving forward on the education and advocacy and the patient support groups. Again, there is no professional organization devoted to educating patients in uterine fibroids in Egypt. Patients can get their information from websites or social media pages, and these are often mediated or moderated by doctors, clinics, or hospitals that are offering this service as their personal initiatives. And of course, for those private service entities, such educational material is mainly for showing their experience and their skill with treating such fibroids or such tumors. Some patients get their information from the TV talk shows, which might allocate or might assign some of their programs to discuss some health problems, one of which might be the uterine fibroids. Usually, those TV programs or talk shows are interactive in terms of allowing patients to ask questions through a telephone line. Unfortunately, none of those kind of sources for patient information are systematized or are institutionalized. So if a patient has to go to an advocacy group to get information, unfortunately, that's not available in Egypt. And another negative negative item that even clinicians get because of the lack of the patient support groups is we need to have patient voices heard when we look into kind of the country-specific guidelines for treating those tumors. So the voice patients or the voice of the patients need to be heard by other patients and by physicians themselves to be able to engage patients to get the best treatment outlines available and acceptable to the patients. So this is one of negative part of the care for fibroids in Egypt that needs to be addressed. This is just a screenshot from one of those TV shows. This is from the well-known Al Jazeera space channel in the Middle East. And as you can see, the title in Arabic is about uterine fibroids. And this is the phone numbers that the patient can dial to get in contact with the guest, who's usually an expert in the field, to get their questions and try to answer them. The policy. A lot of things about the policy needs to be changed. First, we need to change the mindset of patients and of the physicians as well about the fibroid, the nature of fibroids. Fibroids are essentially benign. The risk of malignant transformation is extremely rare. So there's no point that you go for an asymptomatic fibroid and offer a surgery or ask for a surgery just for the thinking that it might change to malignant in the future. If they are asymptomatic, you don't need to go to surgery. This leads to overutilization of the surgery. Another thing is understanding guidelines on how to deal with fibroid-associated infertility. Not because a woman has a fibroid, this means simply this fibroid is the cause for her infertility. So if we remove this fibroid, you'll get pregnant. And that's another very good reason for overdoing surgeries for fibroid in my country. And this is something that we need to change the mindset of the physicians and for the patients about. And number three, the alternatives to surgery for treating uterine fibroids. Although surgery might look the easiest and the shortest cut by the surgeon just to get rid of the bleeding problem or the pelvic pressure symptoms, but there are alternatives and these can save the patient unnecessary surgery. We need to think about this and consider those. Another thing that policymakers, physicians, and patients need to come together to is how to improve the access to care for women with uterine fibroids. As we mentioned, a lot of obstacles and hurdles that prevent the utilization of some of the treatment options by the patients, including the cost, the unavailable facilities like the endoscopic procedures, like the MRI-focused ultrasound surgery, or the unavailability of medications like the GnRH antagonist, or the cultural issues that would promote a woman to accept the heavy menstrual bleeding as cleaning her body of impurities. And so she lives with that. She does not speak up about it. She does not ask for treatment about it. So those are some of the cultural issues that need to be changed in the mind of patients and their families and the whole society as well. Another thing that we need to change about the policy is to allocate more funds for the uterine fibroid treatment and research. A negative thing on the fibroid funding is that people look at it as a benign tumors for which surgery or surgical options are available. So we don't need to investigate more about those. No, they are benign, yes. Some surgeries are available, yes, but they tend to recur and they are very, very, very common. So we need to understand why they develop in the first place in order to be able to prevent and treat those fibroids. So more funding for uterine fibroids is needed. For the research, in Egypt, many research groups have been active in fibroid research. I'm just here mentioning some of the researches that came out of our own group. So we worked on studying the bisphenol A concentration in the uterine leiomyoma, and we found the bisphenol A accumulating in the fibroid tissue more than in the adjacent myometrium, and thus we implicated this environmental toxicant in the pathogenesis of this disease. Another study here where we looked into the thyrocytes, which are stem cell nursing cells in the uterine fibroids, and we found them in the fibroids to be more in the myometrium, indicating they may be playing a role in nursing the stem cells or stimulating the leiomyoma stem cells to develop the tumors. And another study by our group, again, on the vitamin D accumulation in the uterine fibroid, and we found that the fibroid tissue at the tissue level has a state of hypovitaminosis D, and probably one of the reasons or one of the explanations for this is the overexpression of the catabolizing enzyme of vitamin D within the uterine leiomyoma tissue. So more is needed on the research side of fibroids within our communities. We need to investigate the actual prevalence of uterine fibroids in Egypt, because actually we found no studies on the prevalence of fibroids in Egypt, and look into the determinants of the disease, the risk factors within our local community. We need to have a questionnaire for a fibroid-specific questionnaire for the quality of life of patients with uterine fibroids. There are questionnaires out there for fibroids, but they are in foreign languages, English particularly. So we need to have the Arabic translation and validation of the uterine fibroid specific quality of life questionnaires. Improve or look deeper into the basic science of fibroids to understand how they develop and how to prevent or treat them with novel medical therapies. And we need also to do more clinical research to decipher the relation between the fibroids and the subfertility, and the fibroids and heavy menstrual bleeding, to look into if we need to treat and how and when to treat the fibroids to stop the infertility or the heavy menstrual bleeding. At the end, I would just acknowledge and thank all my colleagues and faculty staff members at OBGYN Department, University of Asyut. I would specifically mention specifically Yusra Mukhtar for helping me with getting the statistics from the Women's Health Hospital, University of Asyut. I would like to acknowledge Dr. Ayman Al-Hindi, my mentor in the United States University of Chicago, who first introduced me to the uterine fibroid research. My mentors from the Amsterdam UMC, Filia Mijatovic, Nils Lambulk, and Lisette van der Hoeven, and from the FIGO, Dr. Malcolm Monroe and Dr. Hilary Critchley. And thank you very much.
Thank you, Dr. Ottoman. Now we will hear from Dr. George Makoni, a general practitioner in Zimbabwe, whose areas of care include mother and child, industrial, and mental health.
This is a presentation by Dr. George Brian Makoni. I'm a family practitioner and medical director at Hwange Medical Center in Hwange in Zimbabwe. I shall make this brief presentation in the context of my work as a general practitioner in Zimbabwe. We'll start off with the issue of statistics. These may be available at country level, but clearly they will always understate the extent of the problem. The statistics will indicate those cases that enter the formal health sector because of specific symptoms, such as pelvic pain, irregular PV bleeding, infertility, and so on. They will miss out completely those cases which are not gross enough to pick up on manual palpation, and those where ultrasound investigation is either not available or not affordable. And this is a very large number. In terms of treatment options that are available, for practical purposes, surgery, either fibroidectomy or hysterectomy, is the preferred option where resources permit. Because uterine surgery involves matters of family dynamics, potential beneficiaries often decline to undergo surgery if sufficient family, or more specifically, spousal consensus is not forthcoming. Put simply, a hysterectomy may remove the fibroid uterus, but also destroy the marriage as well. A frequent dilemma for the African woman. Therefore, other less conventional methods become worthy of consideration, for example, herbal medicine, faith-based spiritual approaches, and so on. I'm not at all qualified to make pronouncements on the physical success of these methods, but they definitely can have a place in the mental health component of managing the woman with fibroids, especially when she cannot access surgery. In terms of education, broadly speaking, this necessarily has to be very broad-based to include clinicians at all levels, women's groups, faith-based congregations, school health clubs, and of course, support groups involving persons or families who have experienced both the trauma of uterine fibroids and also their successful and effective management. The education effort needs to be continuous and holistic in order to generate a groundswell of continuing support. There are issues to do with policy. In brief, there needs to be a deliberate effort at national level to establish a much greater access to basic ultrasound facilities, perhaps delivered by cadres such as nurses or paramedicals. This would improve the early basic diagnosis of fibroids and allow earlier interventions which permit salvaging of the uterus in more cases than is the case at present. A more liberal approach, therefore, to the use of ultrasound, in my view, would improve the situation. Another consideration could be the setting up of appropriate woman-friendly counseling centers and centers which could incorporate breast and cervical cancer screening together with uterine ultrasound to exclude fibroids. The major requirement in this instance would be training, as well as publicity and basic ultrasound facilities. In terms of research, there is no doubt ongoing scientific research is happening in specialist gynecology units, but a more broad-based approach, bringing together all health cadres with an interface with the woman with fibroids, would squeeze more value from the current scarce research funding. In conclusion, let us all strive to provide a helpful, effective, accessible, and affordable service to the patient with uterine fibroids and her broad family. Thank you.
Thank you, Dr. Makoni. Next, we will hear from Dr. Mama Say and Dr. Awa Deme. Dr. Mama Say is a professor of medicine at the Sheikh Anta Diop University in Senegal, and she specializes in the diagnosis of developmental abnormalities and also in the genetic infertility. Dr. Awa Deme, a genomic specialist for the Senegal Gates project at Sheikh Anta Diop University. She coordinates genomic research activities carried out with the US partners and local partners, such as Senegalese National Malaria Control Program. Dr. Deme obtained PhD in molecular biology, and her research focus is on parasite genetic diversity and the molecular drug resistance testing.
So before beginning this presentation, I want to thank first all the organizers of this conference, and especially the team that invited us to share our experience in our daily practice concerning the management of uterine leiomyoma. But before, maybe I will present myself. I'm Mama C, and I'm professor in the Faculty of Medicine at the University Cheikh Anta Diop of Dakar, and I'm the head department of histology, embryology, and cytogenetics. And I'm here today with my partner, my partner in research, my friend, Awa. And so I will let her present herself. So Awa.
So hello everyone. So I am Awa Dem. I am a molecular biologist and the lead of the genomic platform at the SIGA Center. So I will be working with Mama on this project on the genetic aspect.
So we know about the definition of uterine leiomyomas, and they are also known as the uterine fibroids or fibromas. But the important thing is that it is the most common tumors of female genital tract in women of childbearing age. And if it is easier to have some data concerning the financial impact, especially in Western countries, it is much more difficult to have available data concerning this financial impact in our country, because it is probably underestimated. The first reason for that is the fact that most women can't afford the surgery, and the hysterectomy is not the first intervention because of cultural context. Indeed, patients prefer the myomectomy, and due to cultural norms and belief, uterus is related to feminine identity. So there is a very popular belief that tells you if you undergo a myomectomy before being pregnant, you won't have any baby. So most of the time, even when the myoma are early detected, a lot of patients run away to escape from surgery. And it is a point that the surgery is a tardive surgery. So women live with an increased morbidity. And finally, when the surgery is possible, there is a longer post-operative recovery and sometimes some sequelae. And even if they don't admit it or confess, traditional medicine is so important that most of the women frequent myoperics. And we all know the dangers of phytotherapy when it is not, when this phytotherapy is not correct. I wanted to insist on the point concerning to the reproductive issues, because there is a lot of psychological suffering because of infertility, because infertility is a kind of reflect of social consideration. And most of the time, even when a woman wants to do the surgery and she's motivated to do it, it is because she's waiting a pregnancy. So I absolutely wanted to share this work that had been conducted here in Dakar. It concerned the fertility after myomectomy in our context of work. And you can see, observing here the data, that after 2 years after the myomectomy, you have less than 50% pregnancy, and that concern the population of the women under 35. Ethnicity is another important thing that is important for us, because we know that African women have 3 to 9-fold higher incidence of uterine leiomyomas when we compare it to Caucasian women. And there is a lot of obstetrical complication even when they are finally pregnant, as some abortion, and etc. We also notice that tumors are larger and more numerous when it occurs. And to see that kind of images after a surgery is unfortunately not something anecdotal. And it would be easy if it was only one surgery, but because most of the time when you are with those women, they will tell you, I had 2 surgeries or 3, and it is a little nightmare. If we could compare to a monster, we'd say like it's like the you cut and it comes again. So in contrast, we can say that there is a little attention has been directed towards etiologies and pathogenesis, and because of their rarity of their malignant transformation, and the fact we are deeply convinced that elucidating the molecular pathogenesis of leiomyomas should be relevant for new treatments. So the new trends in research concerned genetics, epigenetics, and tools in that field of research has been revolutionized by access to next sequencing generation. So if there is a cytogenetics component in this disease and also an epigenetics component, we know now that in genomics, there are 5 genes that are the main genetic drivers of those leiomyomas. And if we focus on MED12 and HMGA2, we can see that they are at the starting point of the pathways that contribute to the leiomyoma. And it is well known now that overexpression of HMGA2 gene is responsible for tumors with big size. Together, when you take them together, MED12 and HMG2 may account for almost 80 to 90% of all leiomyomas. So we think that maybe targeting the consequences of these changes could be a promising strategy in the to develop new treatments. HMGA2 tumors have been described as larger. And we know in our practice that we experiment large tumors within our patients. So with some colleagues, we try to gather our little means through our society that is called the SAFEC, and we try to conduct a study and to evaluate the expression of this gene and especially the protein in the uterine leiomyoma for a little cohort of patients that underwent surgery for myectomy. So it was a retrospective, descriptive, and analytical study. And we used immunohistochemistry to study the expression of the protein. So what are our results? It occurs in young patients. The mean age was 34 years. And the thing that the mean size of the tumors was 4 centimeters, 0.25. When we did the lab, we labeled the tumors, we noticed that concerning the sample, 76.1% of patients were concerned by HMGA2 overexpression or expression. And here we can see quickly images that we could observe after the labeling when it was positive or negative. The other interesting thing was that in the case of expression of HMGA2, the mean size of tumor was 5.8. And when you compare it to the sample concerning the negative expression, there were a difference statistical difference, a difference on the statistical point of view that was significant. We compare our results with what we could find in the literature, and we try to see what was happening, for example, for Caucasian population. Here, for example, from a study in Finland, and it was interesting to notice that the expression of HMG2A2 was much more lower, with 3% if we compare it to our sample. We went to see another study in the United States, and it concerned also Caucasian women, and we observed that the expression of HMG-A2 concerned less than the quarter of the sample. So it was much more interesting for us to know more about this gene and its expression. And we discovered in this paper that the expression of HMG-A2 was related with androgenic factors. So considering the pathogenesis of leiomyoma, the expression and the overexpression of HMG-A2 is related with the promotion of angiogenesis. And it could explain, consequently, why by increasing the vascularity, it allows tumors to grow with large size. So in conclusion, we can say, according to the data of our study, that there were an expression of HMG-A2 in the majority of our cohort, and there is a fact that we observe larger size of myomers when HMG-A2 was expressed. So this work has been published in the Journal de la Société de Biologie Clinique du Bénin, and it's for us a starting point for new challenges in research, because we are more convinced after that elucidating molecular pathogenesis of leiomyomas will help us to find clues to develop new treatments. So in our perspective, what we maybe want to do is first to validate our results with a larger cohort and ideally a multicentric study, and then study the genomic profile of leiomyoma in our population because of ethnical specificities we noticed. We especially want to explore factors of angiogenesis in the case of HMG2 overexpression, because we think that maybe it could limit the growth of tumors. These future studies will be the big opportunity to explore family cluster with Mendelian forms of leiomyoma. And also we want to explore and do a phytotherapy evaluation, because our patients use some plants, and maybe some plants can be promising if they have an action or positive effects in traditional medicine. And it's a very exciting issue for us. Well, we can say maybe that in our university, our strength is that we are on a medical campus, and the collaboration between all the platforms that we have helps a lot to do our research. Research is expensive anyway. And in conclusion, we want just to say that we think that pathogenomics is opening new fields of research and new therapeutical perspective. Leiomyoma is a real public health problem here in Africa, and we think that research for new therapies offers very promising issues, and it will be the possibility to improve life of millions of women. So I want to thanks again and give special acknowledgements to all the persons that are supporting me, And thank you again. Thanks.
Joining us from the United States is Dr. Phyllis Lippert. She is a professor emerita of obstetrics and gynecology, Duke University School of Medicine in Durham, North Carolina. Dr. Lippert has been studying uterine fibroids for over 25 years and has cared for many women with these tumors.
Hello, my name is Phyllis Leppert, and I am the president of the Campion Fund. I am also professor emeritus at Duke University. And it's a great pleasure to be able to talk to you today about a project that I'm working with with a team from Duke and Johns Hopkins and North Carolina University in the United States. The topic is a new treatment option for uterine fibroids, an injectable enzyme. The people who are on my team are Jim Seegers, Darlene Taylor, Ruchitra Singh, and Frederica Jays. We all know that fibroids are benign tumors of the womb. They're very common in women of childbearing age. But what not all of us know is that each fibroid contains large amounts of collagen and other extracellular matrix proteins. It's important to understand that these tumors grow by accumulation of the collagen and other proteins. The collagen is in the space around the cell, and the cells, the fibroid cells, produce this collagen, and that's how fibroids grow. The growth is influenced by hormones, many growth factors, and mechanical forces, as we know. What's interesting is that fibroid cells grow also, but they don't die normally as they would in a normal cell cycle, but they keep on growing. This shows the life cycle of the fibroid cells, and it was work done by a colleague of mine, Darlene Dixon, and her colleague, Dr. Flake, who were pathologists. And it shows that the fibroid cell changes from the normal myometrium. It may come from a stem cell, we're not sure exactly, but this transformed cell begins to proliferate and then secretes all this collagen. And this is the area or the stage that we're going to talk about in the research today. We all know that over many years, the fibroid cell undergoes other changes, and eventually, probably after menopause, it goes through a process of cell death, which the pathologists call inanosis. Now, the important thing to know about fibroids is to understand that the fibroid tissue contains a large amount of collagen. This is a microscopy slide showing a staining with Mason's trichrome of a collagen in the fibroid. The collagen is blue in this particular staining procedure. Now, this blue collagen represents collagen type 1 and type 3, and that's very important to understand. The collagen in the fibroids is very different from collagen that is found in the myometrium. In the myometrium, the collagen shown here in an electron microscopy, which is a very high-powered microscope, shows that the fibers, there's strings of fibers, and then the round areas are also fibers cut in a different angle. And they are very close together or closely packed. But in the fibroid, they're very disruptive. They really are crazy. They go all over the place. And they're widely dispersed, and they just are not normal at all. They're also very short. The other thing we know about fibroids is that they have a great variation in appearance. Each fibroid comes from one particular cell, and each fibroid is very different from other fibroids. And we showed that the fibroids can be swirl-like, they can have large nodules, they can also have a trabecular appearance. And this is important to understand because fibroids are different from each other. They're also different if you have many fibroids in one uterus, each fibroid is different from the other. And this is a challenge in doing and in discovering treatment. Now, we were interested in the collagen, and we thought that a collagenase, which is derived from a bacteria, and it's highly purified, would be helpful in sort of melting away or dissolving the collagen in the fibroid and perhaps helping it shrink. Now, it's important to understand that this particular collagenase that we're working with is used in other diseases, in the treatment of other diseases, and it's already FDA approved. We know that it only breaks down or dissolves or melts away type 1, 3, and 5 collagen. It does not touch the type of collagen type 4, which is in blood cells blood vessels or in nerves. So that's a very important thing. We showed that we could inject the collagenase into tissue. These are tissue pieces that we got at the time of surgery. But you can see with the black arrow that the tissue is starting to sort of liquefy and dissolve. And then we also studied it by taking small pieces of fibroids. And the study that we did various doses of this collagenase, and we showed that at the highest dose, we got a great deal of tissue melting or dissolving. And this dissolved tissue or broken down collagen is then excreted by the white blood cells. It's picked up in the blood by the white blood cells and eliminated from the body. We then, working with our colleagues at Johns Hopkins, we did a clinical trial. We were interested in finding out whether we could actually inject this into the fibroid safely and what would happen to the tissue. So we studied a small group of women, and this just shows the schemata of how we did it. I think it's important to look at group 1, which was 3 subjects, and we injected the fibroid, and then 48 hours later, at the time of hysterectomy, we were able to look at the tissue. The second group, which is the most important, was group 2, and that was 9 subjects. And we injected the fibroids with the collagenase, and then 60 to 90 days later, we did the surgery and looked at the tissue. This slide shows how the injection was done. Under ultrasound, we injected a needle into the uterus and into the fibroid. And you can see the needle shadow as the blue arrow is pointing to that. And the study drug, which is injected, is shown by the gray arrow, and it's that little white area at the end of the gray arrow. What we did then is we looked at the collagen in a fibroid that was not injected and one that was. And we showed by staining that the blue or the collagen was very much decreased. And we looked at it also in another analysis called image J and was also decreased. Now, when we look at the specimens at the time of surgery, we can see that the collagenase, and it's stained blue with a special dye, only got into the fibroid and not into the myometrium. One thing that's very interesting about this enzyme, and an important part of it, is that as soon as this enzyme gets out into the bloodstream of people, it is inhibited by the special proteins that we have in the blood. So it's inactivated. And the slide part B shows that there's a little indentation showing how that collagen in that area was melted away or destroyed. And this shows in another way that we really were successful in decreasing the amount of collagen within those fibroids. It's reduced quite a lot. The black area is the treated fibroid, and that was a very good result. We were very happy with it. We also looked at pain that the women had. And we gave every woman a McGill pain questionnaire, which is a questionnaire that really is very validated and shows how much pain a person has. And in group 2, we did show that there was a great decrease in pain 4 to 8 days after the injection. And then that pain release was also found 60 to 90 days after the injection. And this was a very exciting finding. This slide shows all the patients and how their pain did decrease after the injection of the collagenase. So in general, or what we can say about this particular phase 1 trial, which was to show that we could do this and that it was safe, there was very great reduction in collagen content in all the fibroids. They were soft to touch, and that did show digestion at the site of the injection. And there was a decrease in pain, which was very exciting. And there was no significant adverse events. We are very excited about this because, as I said, this collagenase can be injected into the fibroid. It does not destroy blood vessels or nerve cells, which is important. And if it gets into a person's bloodstream, it's immediately inhibited. And this is a very great thing. So we're working on a procedure that can be done anywhere in any location outside of a hospital that could be very helpful in treating fibroids or as an additional way to treat fibroids. The patients at the time of the injection, they tolerated it very well. It was done with some local anesthetic. And we're very excited about this as a possibility to treat many women all over the world and to decrease the size and pain with their fibroids. Now, the other thing I wanted to mention, which is very exciting, is one of the persons on our team, Darlene Taylor, who is a chemist, has devised a liquid gel, which is a way to solubilize or put this particular collagenase in solution. And the neat thing about liquid gel is that it can solubilize the collagenase, and it's liquid in the syringe at room temperature. But then as soon as it gets into the body, it solidifies, and it can act as a way to maintain the collagenase for very slow release over time. So this is the idea of what we would be doing. The liquid gel containing the collagenase is heat triggered to form a gel as soon as it hits the fibroid, and it delays the localized release of the drug, which makes it able to be released over a great deal of time, preventing the need for multiple injections. And it does, we show, release the collagenase and actually melt away the collagen. What's also important about this liquid gel is that it can also interact up to 2 other drugs. So we could use many other drugs along with the collagenase, and we're very excited about this. This is a work in progress. We are working together very hard to be able to do further clinical trials so that eventually we will be able to make this available to women. Thank you so much.
Thank you, everyone. At this time, we will move to our live question and answer session with our presenters. Please put your questions in the chat, and we will get to you.
Excellent, excellent presentation. So that we've heard from all of our presenters. So we do have some questions in the chat, and as a reminder, continue to put those questions in the chat. I'll be your moderator for the Q&A session. So one of the first questions that came in was from Yvonne Maddox, and she asked, has there been research on the rate of growth of fibroids and whether that growth rate is age dependent? So any of our speakers or any of our tomorrow's speakers are more than welcome to answer Yvonne's question.
Dr. Prosper.
Yes, go ahead.
Actually, if you look at the burden of fibroid and age of presentation, you see that if you look, the earliest, probably 16-year-olds to 30-year-olds, the burden of fibroid is the least. And actually, that is more reason why they should present early. Every education for fibroid should actually let the people understand that earlier they present, the easier for management, the better outcome, and even for their future fertility. I'm an infertility specialist, so I know the problems that confront women. And I think we should really, most of our research, I'm interested in the last presentation, presenter's research in collagen, because it's a very important aspect of intervention. I was just listening carefully to that presentation and the clinical trials on board. And I think it is easy to translate that to many African countries and many centers in Africa and see what is going on. And we can get data out of it. Thank you.
Great, great. So Phyllis, since Dr. Igboeli mentioned the collagenase injection, we will jump to you and let you comment.
Okay, thank you very much. You know, fibroids are very tricky because each one is very unique, and there are genetic factors. There are all kinds of factors. But one of the things, and I didn't mention this, but we've done a lot of studies that show that not only do the cells respond to growth factors and hormones, but they respond to local, small mechanical stresses. And the mechanical stresses of a cell, you know, if the fibroid starts growing, the collagen that's produced is stiff, and it causes the cell to change its shape. And as it changes its shape, what happens is the cell genetics change and it starts producing more collagen. It's very interesting. And we don't understand a lot about it, but that is a real crucial thing. And we also know that this mechanical force can also make genetic changes in cells. That's critical and it's very important. So you think about it, and the comment that you made about it starts early in women, young girls start having the fibroids grow very quickly, you know, or soon, up to age 20 or as soon as maybe even menopause. And there are lots of patients that have fibroids that we miss at that early stage. Exactly. And we need to start treating them. One of the things that's also important, and it needs to be done other places, but studies that were done by Donna Baird and her group show that fibroids grow at different rates. Some fibroids just sit there and don't grow. Some grow quickly. Some actually regress, and it's really, really strange.
Exactly.
I think it has to do with this mechanical pressure kind of thing, but we need to be able to sort of put everything together. But one of the things that I think we really need, and I'm so glad you mentioned this aspect, is we need medical treatments that are not costly, that can be done anywhere, and that are long-term. Even GnRA activation and agonists and antagonists, they're short-term because there are a lot of side effects. And we got started on this because we thought an injection, you know, it bypasses the liver and there are not so many side effects and everything. So I'm glad you're interested in this, but you know, I'm also glad that you're saying that you need early interventions and early discoveries, and that's important.
Okay, so the next question came in from Elizabeth Corsari of the Fibroid Foundation, and I believe she was directing this towards Dr. Igboeli's presentation, where she asked, are you saying that physical examination can be used to diagnose a fibroid?
Yes, actually is the key to diagnosing fibroid in Africa. A lot of centers do not have the facilities for ultrasound or other kinds of intervention, but the African clinician is confronted with late fibroid presentation. So by mere clinical evaluation, we can pick up most of the fibroids that have presented in the late stages of their development. The early development is where I'm concerned, because I think that is where we catch them and treat them successfully so they can get better outcome. By implication, if there are things we can do early for African women, which I'm into, I think that is the key. When they come so late, really, even if you do myomectomy, as I told you before, I've done thousands of surgeries on patients with fibroids from all over the world. And somehow, the best outcome comes when the fibroid tumor burden is small, and when you can actually define the anatomy of the endometrium, the anatomy of the myometrium, the anatomy of the surrounding. And most other patients present after they have been castrated, going through spiritual houses. A lot of presenters hit the point. They go through hell, African women. And it's really very emotionally concerned about them, because they are really, yes, they are ostracized, they are stigmatized, they are emotionally raped, and really they go to different.
Une urgence, je pourrais prévenir. Et une urgence, je pourrais prévenir pendant. Merci beaucoup.
Okay, go ahead, Dr. Igboelim.
Me?
Yes, go ahead, proceed.
Oh, please. So I think we should put our head together. This is the first important meeting I've ever gone on fibroid in my entire life, because I look like I'm a lone singer. But I think we have now a platform that we can discuss these matters openly. Women are castrated, they are stigmatized, they are traumatized because of this condition. And if you see them flowing in and out of places, going to areas where they're not supposed to be going, because there are no channels for them to have proper guidance for this condition to be taken care of. Mm-hmm. So I think all of us should be team workers in this environment so we can bring better life outcome for women in Africa. Mm-hmm. Thank you.
Mm-hmm. Wonderful, wonderful. So the next question actually comes from Dr. Ayman El-Handy. Dr. El-Handy is actually one of my advisors at the University of Chicago. So he has several questions here, and some of them are to Dr. Igboelim, but he also indicated that any of the presenters, any of our clinicians on the conference are more than welcome to give their answers. So the first one is, he says, do you think BMI is a factor in African fibroids like in the United States? And it seems that there are more thin women with fibroids in Africa. And if you've seen any actual solid epidemiology on this premise. So any of our clinicians, you're more than welcome to answer.
Let me answer this because it's coming from my colleague. I work very, very closely with El-Handy, very closely, not just on fibroid, but on stem cells. And we are looking into areas where we can actually promote conversion of stem cells, injection of stem cells into intra-ovarian substance to also do some other things for women. But addressing the issue of fibroid and diet and environment, I think that's why we need to know more about the biology of this disease in Africa. I think there are other things. We talked about Net12 issues. We talk about environmental factors affecting fibroid formation. And I think there should be a different mechanism in the African continent. And I believe that if we can actually do segmental study of the biology of fibroids culturally, I believe there may be differences found. They are not the same mechanism. And when we talk about these issues, I think every environment has, I'd like to know what is going on in Ghana, in Kenya, in Zimbabwe, in Egypt. I'd like to know really the intercontinental connection. It may not be all the factors, maybe environmental factors are necessary for formation of fibroid in every little locality. Dr. R. Handy, any comments on that?
He's still muted.
Don't mute him now.
Oh, there he
Okay.
is. Okay.
Hi, good morning. I was really, it's about 6 a.m. in Chicago, and I've been up for the last 3 hours or so. I'm really enjoying this. So thank you, Liz and Lillian, for putting this together. Really outstanding. Yeah, I mean, it's just my impression from Dr. Egupoli. We've been collaborating, and he showed me a lot of pictures. I also visit, different countries. It's just BMI and obesity seems to be very commonly associated with fibroid here. I would say at least, in most of the major cities, at least, it's rare to find a thin person with fibroid here, I would say, in the US, while in at least my limited experience in Africa, it seems not to be as connected. Of course, there are some obese patients, but I see a lot more, normal BMI with fibroid. So I think there's something there, but of course, you guys are the one who do this every day. I was wondering if there's some good epidemiology, or at least your own, impression from many years of practice, if people can comment on this in other countries.
So any of the other clinicians? I see Dr. Chente is with us, Dr. Fofi, Dr. Anand, any of the other clinicians, Dr. Chale, Dr. McConey. So you're more than welcome. Okay, go ahead, Dr. Fofi.
All right, thank you very much for the opportunity. Yes, the relationship between obesity and uterine fibroid, there is a link there, and in our country, we can find a connection when you look at the geographical divide. In the northern sector, that's mid part of the country upward, we tend to have the population that tend to be generally much more lean, and the density of uterine fibroid is not as high as we have in the lower part, that is the coastal belt of our country, where the level of affluence and obesity tend to be much higher. The strange thing, however, is that even in the northern sector, where we don't have as many fibroids, you identify specific cases that tend to be quite huge. So we think there is a link, but that alone is not the only factor, because we are getting so many lean people. The few that have fibroid in the northern sector tend to be very huge in size. So there is a connection, but there is a need for further exploration in that regard. Thank you.
I agree. However, what you need to know is that if you look at the slides during the clinical presentation, all those women, they're really thin. They're not fat. If you look at my slides, I have a lot of slides. I have a lot of photographs, because my interest has been since 1982. I've been dealing with fibroids since 1982. So, and really it's my pet project. So I realized that environmental factors we should look into. Affluence, when you are affluent, you eat well. But I want to tell you that a lot of the patients you see are from the villages that are even poor. They don't eat well, and then they bleed. And when they bleed, they become extremely malnourished. So there's so many things that we need to deal with in the African continent. I am talking about my own environment. That's why I like to know what is going on in Senegal, in Kenya, in Egypt, in Ghana, in Benin Republic, in Congo. We need to know. We need to have an intercontinental collaboration. I use the word collaboration, and that's the way it should be.
Okay, so that's an excellent point. So I see Dr. Chente, she has her hand raised. Go ahead, Dr. Chente. Oh, you're muted. You have to unmute. Let me see if I can ask her to unmute. There she is. Okay, go ahead.
Okay, thank you. I'm sorry to come late. I have an operation and it takes more time. So I'm so sorry. So I was saying that there is a link between obesity and the development of fibroid also observed in our country. We have done a study here in the hospital where the obesity was a risk factor of the development of the fibroid with the statistical signification with the odd ratio about 3 point something. And but you have also observed that in Cameroon, there are some particular region where when the woman, some particular ethnics, where the women are from those places, they tend to have very huge fibroid, very big fibroid. So we think that there may be some nutritional factors also, because what characterize ethnics are they have some particular way of eating or some particular habit. So as Dr. Prosper was saying, it will be very good to try to really look in details to see what are the other factors going on. I think there are many factors. It's multifactorial. Then when you go through, maybe you are going to see it's really just not very good that we have not done some specific epidemiological study to really try to characterize that. But I think it may be something that has to be done.
Yes, excellent. Okay, so Dr. Anand, I see your hand. Go ahead.
Yes, thank you very much. A nice presentation. What I want to say is I share in the sentiments expressed by all my colleagues, Dr. Prosper, Dr. Fufi, and Dr. Kente. We see a bit of relation when it comes to BMI, high BMI, but probably there are more to it than meets the eye. And I'm sure that is why I support what Dr. Prosper is saying. This calls for a collaboration for us to be able to unravel all these mysteries surrounding fibroids in our sub-region. We have a huge patient population, so conducting such studies should be very easy. And probably that is why we should all support what Fibroid Foundation for Africa is doing, to see how best we can be able to help these women. I'm also into fertility practice in Ghana, like Dr. Prosper in Nigeria. And they come in very late. Before they come, they've gone to spiritual houses. In fact, in Ghana, if you go to the market, there are actually loudspeakers proclaiming and telling these women that we have drugs that can melt these fibroids. And some of them will be on these medications for 8-10 years. By the time they come to us, more or less, there's hardly anything you can do to salvage these women. So there is more to it that we ourselves as practitioners, as government agencies, we need to collaborate to make sure that we can be able to put something together to help our women in Africa to solve this major issue that affects most of our women. That would be my initial comment. Thank you.
Yes. So it sounds like the cultural aspect is quite widespread and it varies, across the different nations, because I heard different aspects why women want to preserve their fertility across the different nations in relation to cultural factors. So I believe this is something that that Liz of Fibroid Foundation had mentioned, you know, that many women will not come forward. They're very scared, and just as you all been saying, you know, they have different reasons, even there in Ghana, for why they don't want to say anything about, yes, I have this fibroid. So, Dr. Chinte, did you have another comment, or you just still have your hand raised? Still have your hand raised? And you have to unmute yourself. Unmute yourself. Let's see if there she, okay, go ahead.
So the comment was just to say, as Dr. Prosper was saying, that many women suffer for fibroid, and then they will be suffering for years and years, because they are afraid, because somebody is telling them that, okay, I have the drugs that can heal it. You have also these vitamin and complementary medicine, which come with so many things like forever product that I don't know. And then people will say, okay, use it. They will spend all their money around, but every month when they start bleeding, it's heavy, they cannot go to work, they're still in the house. Then after, they will take some drugs for anemia, ameliorate, and it's maybe 5 to 10 years that when they have been suffering for long, that they will maybe sometime decide to come to the hospital because they have done everything and nothing happened. So it's really important for us to sensitize the women and tell them that, I mean, you can do something in the medical. We try to do that, but it's a real problem. So they suffer a lot. Some women, psychologically, they suffer a lot for long before they can reach to the hospital.
Yes, thank you, Dr. Chinte. So a second question, the doctor actually commented on this, where you all commented on this when you mentioned the social stigma. And he said, can you comment on that, as this may be different from the US? So I think a lot of you have already talked about the social stigma, or if anyone wants to add anything further about the social stigma.
Yes, I am concerned. Empowerment of women is very necessary to overcome the stigma of fibroid in any society, including the United States. But more so, I'm using Nigeria as an example because that's where I have authority to talk anything about fibroid. When a woman, a young woman, wants to get married, the first thing is the relatives, these brothers-in-law, mother-in-law, father-in-law, friends, we ask the suitor, the young man, make sure she doesn't have fibroid.
Wow.
I think it is the stigmatization that bothers me most, truly, because it means that before you get married, I have to find out from below, from the back, whether you have fibroid or not. That tells you a problem in African culture, in my own culture. So these women may then decide, A, to first try to see if they can get pregnant. Remember this now, and I'm telling you as a gynecologist from my own specialty, and as an infertility specialist. And at very young age, they try to see if they can get pregnant, because every marriage in Africa wants a baby. The case is closed. So now when they get that pregnant, they're not ready for marriage. They go for early abortion, what we call illegal abortion, because they don't want anybody to know they even aborted the baby. I'm telling you the truth. Eventually, one crazy, inexperienced that it may not be a physician, maybe a nurse, maybe not a nurse, maybe some quack somewhere, we now destroy that endometrium, then really causing the woman agony of life. So it's a multiple effect, and I think we need to find a way to address it in general in this meeting. Thank you.
Any other comments on the social? Okay. Okay, so his next question was interest in hysterectomy. So Dr. O'Handy indicated that he visits many countries in the Middle East, and many women there equate hysterectomy to loss of femininity or womanhood. So he indicated or asked, how is this different in Africa, or how do women think, or would they prefer a medical or non-surgical option? So I think a couple of you touched on the sacredness of the womb and why women want to preserve their fertility and keep that womb. So if anyone wants to answer his question about hysterectomy and how it's viewed in their countries, feel free.
Somebody making a comment?
Yes, Dr. Chente, I see her. Go ahead, Dr.
Okay. So in our country, I mean, it depends. I work in a general hospital, which is a central, high-level hospital. I mean, not the district hospital, which are the low level, the very first step. So in my own practice, there are very few women when they don't, when there's no a problem of fertility, they don't really have a problem of removing the uterus. Instead, sometimes they will say, okay, now, they will hesitate, but when they take the decision, they say,
I think it's her internet connection.
So far a lot, so if you can remove, but they will not, allow, even if you try to keep their uterus. There are some few, there are not very many, that will say, okay, no, removing my uterus, maybe I will not have sex normally, maybe I will have some problem later on. There are not much of them, but it's true that I'm dealing with a population of women that are a bit educated, because it's not easy to come to my hospital. The fees are a bit high, so it's not everybody who come here. So it's not the same context in the peripheral hospital where you have women who are not educated, but who think just about their femininity, and they think that sometimes if you remove the uterus, they cannot have normal sexual intercourse after, or they will lose their femininity. So that is a comment I can do on the question.
Thank you, Dr. Chente. Dr. Igueli, did you have a comment or no?
Well, I just think we need to understand how the woman feels. In Africa, in my own environment, a woman will never agree to a hysterectomy unless it's so life-threatening. And even they rather die sometimes. They present too late. They can present with when they have very little blood left and it's emergency and they cannot sustain surgery for a long period of time. And then that is when a hysterectomy is done. Or when you have very difficult problems like repeat myomectomies, where there's intra-abdominal adhesions and you cannot really dissect the fibroids out without injuring the gastrointestinal tract or something. That pelvic floor, the endopelvic fascia, from there, when you remove it, then it really has to be very difficult for them. And they don't feel the same again. when you say you're removing their womb for fibroid. They rather would like the fibroid to go through all the herbs, intravaginal insertions, destroying everything. I don't want to, it's a difficult thing for me looking at African women suffer through all these things.
Yes. And just as I see in the chat, our sister Amoy from Womb Care has joined us from Canada. And she indicated that she's doing a qualitative study of Black women with fibroids, and it is a huge problem there in Canada. And that she's also happy to collaborate. I think she had another, has there been any education done with African women on the management of uterine fibroids? And I know a couple of you spoke about, actually all of you spoke about education and advocacy and support groups. So any of you willing to or would like to tackle this question, go ahead. See, I think someone is unmuted. Go ahead, Dr. Anand.
Thank you very, very much. I think on the issue of education, you can imagine this is a condition that affects a greater percentage of our women in the reproductive age group. But if you look at data from most African countries, if you look at the 10 probably causes of disease or mortality, when you will not see fibroid disease in there. And so nationally, you don't see nations in Africa championing for the issue of fibroid. Most of the education, for example, in Ghana is based on small women groups, care groups, where probably a doctor will be invited to talk about general issues of menstruation, and then fibroids will be roped in. Because we don't have any bodies that champion advocacy for fibroids in my country, Ghana, or probably in the sub-region. I don't know whether my senior colleague Prosper will agree with me. And so the onus lies on us. We are at the forefront of women's health. Once we realize the enormous problem fibroids cause to our women, I think the onus lies on us to make sure that we spearhead it and get people, politicians and others to join in the process of making sure that women get the right education, because they don't have the education. They will sit at home and think that, oh, anything goes. Whilst when they come and see us in the early stages, there are a lot of things that we can do.
Oh, Dr. Anand, your volume is decreased. Well, let's see, he muted him. Okay, there he is. Okay, go ahead.
Yes, so as I was saying, education should be at the forefront, because the problem of fibroids, we have an endemic problem with fibroids in our sub-region. We all agree to that fact. But as I said, for example, taking Ghana into consideration, we don't have any national issue when it comes to education or advocacy. Most education is based on national bodies. They invite a doctor who comes to them, and them may rope in fibroids in, and then that is usually how the education goes. But the onus lies on us, being the leaders and advocates of women's health in our sub-region, to make sure that we join hands and see how best we can get politicians, even educators, the universities, those of us involved in teaching medical students. I think there should be more or less a global or a united front when it comes to education, because once women are also wise women. It's not that they decide to stay at home and not come for care because they don't care about their health, but they don't have enough information and education on the problem these fibroids cause. Some of them think that, more when I talk about stigma, some of them think that even there are spiritual causes. So why don't I go to a church and be prayed for? And so the onus lies on us to make sure we hammer on education, get groups when it comes to advocacy to educate these women. Now, to be able to make inroads gradually until finally it becomes fully accepted by all our nations in sub-Saharan Africa. Thank you very much.
Excellent point. So I see Liz from Fibroid Foundation Africa. Go ahead, Liz.
Yeah, thank you very much. It's been a wonderful time talking about uterine fibroids. Uterine fibroids make women victims. And indeed, when they become victims, they become so vulnerable. And Dr. Prosper has said it all. We become so vulnerable that we take everything that comes our way. So when you're talking about education, sometimes it is difficult because most of the education that we have around drug peddlers, they go to the radio stations, they go to the TV stations and go and sell their drugs and other alternative treatments, which women easily fall prey to. I have come across so many women who go about buying gallons and gallons and gallons of concoctions. They drink them over and over and over, and they don't get any solution. And yet, the doctors are aware, the community is aware, our medical practitioners are aware, some in government are aware. I'm saying this because when I started this education and advocacy program, I have come in contact with so many health personnel, and they will brush you aside that, oh, this is just women issue. It's like you are just making a fuss. What is about menstruation? If you are menstruating for over a week, 2 weeks, what is wrong with it? Okay. So just as collectively we've come together this afternoon, I think it's afternoon here in Ghana, so you can understand. I think education is key. What we do as Fibroid Foundation Africa is to reach out to women wherever they are. We go to the markets where we get a chance, we go to the radio stations, and it will surprise you at the number of phone calls we receive after this interaction. Just yesterday, I did a program, I think a year ago, and a woman called me that she listened to me on one of the FM stations, and she just got married and she's bleeding. Just yesterday, about a year ago program, she's bleeding and she's calling me to find out if she can still have birth because she got married to a new man and a new husband in December. And I was touched, and I was telling my son that these little things that we're doing, see how far they go. So I think if we step out educational programs, I think it will bring so much relief to many people. They will understand, they will know that there are people there for them. And these educational programs cannot be structured by we alone as a foundation. It should be from the top. It should be from Ghana Health Service, as in the case of Ghana, through collaboration. There should be IE&C materials, there should be posters, there should be handouts, there should be flyers, all in different languages everywhere. You enter a hospital and they are lying there, you take them, you read them. There should be things shared on the street for people to read and understand that when you have fibroids, it's not about concussions. Go and see a medical officer. So we are doing the little bit of it in our own capacity and what we have in our hands, but I think there's more to do. And I thank you very much, all of you, for coming together this afternoon to let us deliberate on this issue. Thank you very much.
Yes, thank you. Thank you, Liz. And then I see a question. And I think all of you actually spoke about this, but it is relevant given what Dr. Chente mentioned and what you've all mentioned about concoction. So Dr. O'Handy asked the concept of prevention. So can you comment on the utility of early intervention in young women with very small fibroids with a simple nutritional supplement like vitamin D or so to prevent progress of disease? So he asked that you please speculate on the health and economic impact of that. And I know Dr. Igboeli knows well about vitamin D as a treatment for uterine fibroids. So the floor is open to all of you to comment on this question. Let's see, is someone commenting? No, okay, no, so that I thought that person was going to comment. Anyone?
Does anybody else want to comment before I comment?
Yeah, I see Dr. Chente. Go ahead, Dr. Chente. Let's see. You can unmute. There she is. Okay, she's unmuted.
Yeah, no, just to say that I really don't have an experience of that. That means you have not tried to integrate nutritional or vitamin therapy in the prevention or in the management of the fibroid in our country. So I have not seen even physicians or nobody. So I think it should be a good thing to try. I don't know if people have experience of that. Maybe they share it, and then you can set some strategies how to bring it about. But we don't have any experience here about the supplementation of vitamin D and the prevention or the treatment of the fibroid. Yeah.
Okay. Okay, I think Dr. Prosper is going to take this.
First of all, is our handy Amen. Are you still here?
Yes, I see him there. Let's see, Dr. O'Handy, can you unmute yourself? Because Dr. O'Handy is actually going to present tomorrow on EGCG and vitamin D. So this is actually a good question. And I don't know if we want to address it now. He's unmuted now. Go ahead, Dr. O'Handy.
Yes, no, I'm here, of course. I've been here all the time. And just, I really enjoy listening to all this discussion. Just amazing.
Yes.
But yeah, I want to hear from you, Dr. Prosper, because I know we talked many times about this. This is kind of our dream, but I think everybody would like to listen and hear from you.
Okay. Amen. Are you still talking?
No, he turned it over to you.
Yeah, please go ahead. Please go ahead.
Actually, really, because of my passion for this disease, I came to America in 2016 and worked hand in hand as collaborators with our Handy. And we published an editorial in 2020 on the possible beneficial effects of this particular medication that is very cheap and with very little side effects for implementing early utilization in many patients that are young. Actually, my thought process in the first instance is to use this as a contraceptive, just like you use contraceptive. When these people are like 16 years of age, you start them on vitamin D and follow them up in a longitudinal study for up to age 30. And the maximum age of fertility is 24 to 25 years. So what I think will benefit us, if we can prove it to be correct, is to initiate early intervention. I use the word early intervention because if you look at my graph, I took a study of my patients. I looked at the data bank. I have about 2,000 to 3,000 patients that I have taken care of, operated upon for fibroid. And I looked at the different times it presents. Granted, I'm an infertility specialist. A lot of people will not come to me. Remember, they are going to prayer houses, they are going to churches, they are going to non-specialists in the villages. We're talking about 200 million people plus in Nigeria, for which 51% or 52% of them are women. And you look at their age brackets, you find out that people in their late teens and early 20s and late 30s, late 20s, that their fibroid burden is so less. I have a graph actually in the Lillian. You saw my graph?
Yes.
Okay. You see that before the age of 29, 30, that there's an exponential growth in that graph telling you that there's a window of opportunity. And that window of opportunity is what I really think we should capture. And when I listen to Liz's presentation with colloid injection, everything comes to my mind. Because we can, Dr. Al Handy will tell you that we've been trying to transvaginally inject stem cells into a women's ovarian environment to stimulate them to begin to produce estrogen or things like that. Okay, we enter a lot of collaborative research together, but I think this is things that really pertains to us. And ultrasound is a very inexpensive equipment, and actually you can do this Liz's presentation, colloid injection. We can do it by transvaginal and ultrasound guided just into the intrauterine myometrium, the collagens. We know a lot of things that can be less expensive. Going through surgery is very difficult and dangerous. I use the word dangerous in an African environment.
Yes.
Whether we like it or not, electricity is not there. The NEPA, what we call interruptions of power. And there's so many things that really we should look into to look at very inexpensive interventions that will yield us the best result. And I think utilization of vitamin D is really inexpensive, non-invasive, and then that everybody can lay hands on, and then we can all study it in all our different countries.
Yes.
Thank you.
Yes, there's your dream study, Dr. O'Handy. Yeah, so any other comments on this question? Okay, so the next question, and I see also we have one from Constance, but I'm going to give this last question about commenting on the impact of anemia caused by fibroid heavy menstrual bleeding on patient health and productivity and the overall economic impact at the public level. So this heavy menstrual bleeding, if anyone wants to answer this question. Okay, no, Dr. Chente?
Yeah, we have not evaluated that impact, scientifically to really see, but what we all know and what we all observe is that some women, when they start bleeding, they cannot go to work because they are bleeding so heavily that they just tell you when the menses is there, she has to be absent to work because she have to manage. If she go there, she'll be having blood every time. So there are many people who will stay just at home waiting that the menses cease before they go. So, but doing a study for that evaluation, you have not yet done that to really impact it. But there is an impact. Really, truly, there is an impact. Yeah.
Yes. Yes. Dr. Anand.
I agree with my colleague about probably we don't have studies on economic impact of most of these conditions in our sub-region. But I do agree with her that, if a woman is anemic, then she is weak. And so when she's weak, she's likely to stay away from work. She works for the markets, corporate world, she's a teacher. All these things are affected. And for example, in Ghana, getting blood transfusion is another difficult issue. So if a woman comes in that late, severely anemic, and have to give blood transfusion, then there's also another issue of even getting access to the blood, got a compounding effect. That is why if we step in earlier, give these women education at a younger age, secondary schools, about menstruation. In fact, it's probably a myth in Ghana among some of our women that when a woman menstruates, the blood must come, it must be heavy. It means that a lot of death in your system is coming out. Some of our traditional women. So even those who menstruate few days, 3 days, and it's light, They will come to you and say, doctor, these days my menses have changed, but that doesn't come like I want it. And so all these things are issues that we have to bring to bear on the lives of our women. But we know that fibroid has a burden when it comes to heavy menstrual loss. And probably medications to be able to help control them is something that we have to think about. All these come with cost. That's why education is the best thing. And the earlier we step in, thank you.
Yes, thank you, Dr. Anand. And then our question from Constance Mandan.
Can I?
Oh, go ahead. Sorry. Go ahead, Dr. Igbo.
I just want to add more information to what Dr. Jude just said, because it's correct. But my concern is that actually we should have a research in terms of the number of patients that die in the villages, meaning that faint in the markets.
Yes.
It's hemorrhagia associated with fibroid. There are many that are undocumented. You see, there's this problem here. We are all educated. We live in very high places. I live in Abuja, capital of Nigeria. That is a high-class area. But when you step 100 miles down the bush, you really see people dropping dead from, and they don't have any death certificates. They just die. They die from exhaustion, they die from bleeding, they die from every day. And the reason why I know this, incidentally, I treat the poor, the middle class, and the very rich. Okay? So we need to find a way we can penetrate, like advocacy and education we are talking about. Very important. So the villages, we have to capture the population. The population of every country is not in the city, it's in the villages, especially my own. Okay, so we have 200 million people. Let me give the cities 30% of the population, but they are not up to 30%. What of the 70% that we don't know anything about? We don't even have data to support them. So we have to develop all these interventions. Really, my interest is to get to the root of the problem and then to get the poor, the middle class, and the rich to benefit as well. Thank you.
Thank you. Excellent. So we have a question from Constance Mandangenda. And she said, her question is, what are the behavioral risk factors of fibroids? So behavioral risk factors of fibroids, if any of the clinicians want to tackle this question. Because I've heard all of you talk, or some of you talk about genetics, environmental, diet, but behavioral risk factors of fibroids. Yes, Dr. Chente.
Yeah, I didn't get you well. Please, can I didn't get the question well. I didn't get the question well. What is the question, please?
So the question from Constance, she asked, what are the behavioral risk factors of uterine fibroids? And are there risk factors?
Yeah. Yeah, the behavioral risk factors, I think they are those factors that will link to obesity. That means if you don't have physical activity regularly, if you eat too much, you are obese. Those are things that we can control. You see, what we eat, the physical activity, yeah, you can act on it, not to become obese and all that. Then for genetic factors, there is nothing to do. When you are in a family where sisters and mother are predisposed to, there is nothing that you can do. And other factors like early menarche, or you cannot do anything. But delivering, having a child early have been shown to be also a protective factors. because those who stay for long and have a child at late age, later than 30 or 35 years, have more chance of having fibroids. So if you going on, try to have your children a bit early, I mean, it may be a protective factor. It might be what I can say. That's all.
Thank you, Dr. Chente. Let's see, any other questions? Want to answer the question about behavioral risk factors? Okay, see, Dr. Yeboah. Dr. Yeboah, you have to unmute yourself. Let's see.
Okay, yeah.
Okay, there you are. Yes, go ahead.
Okay, thank you very much. Sorry for my late being on the program. I was operating.
No.
I just heard about behavior risk factors.
Yes.
And the only one I can think of is delaying pregnancy. As long as the uterus stays ungravid, not getting pregnant, uterine fibroids get a chance to develop. So the only behavior risk factor that I can think of at the moment is staying away from getting pregnant. You know, some women will say, let me get married. It's good to get married to get pregnant. If it is delaying, some demand, you know, weddings to a level that the man might not be able to afford. And that alone would delay pregnancy. And as you stay not getting pregnant, the uterus, the fibroid nodules get a chance to develop and grow bigger and bigger and bigger. So not getting married early. In fact, I've realized in my practice that women, it's not the best having recurrent abortions, like every now and then coming to have induced abortions. But I realize in many women who have had many induced abortions, because you get pregnant, your menstrual flow delays in a way. Before you get back on your cycle, the body assumes you are pregnant. And once you're pregnant, more or less fibroid nodules do not get a chance to continue to develop. So many pregnancies delay or prevent the development of uterine fibroids. And in our environment, women who have had many children, 5, 6, 7, you hardly see fibroid nodules develop in them. So that's my little contribution.
Thank you, Dr. Yeboah. Any comments? Any other comments? I see Dr. Olutosin. Did you want to comment? And you, I'll make sure you unmute yourself.
Well, sorry, thank you. I think I've tied my question on because I've been thinking about obesity and fibroid, the link. I've always thought that because obesity, fibroid, both of them have estrogen relationship. I'm just thinking, could it be rather the two of them are product of some common factors rather than one of them causing the other. I mean, that's just my thoughts.
Yes, I see it. So Dr. Olutosin asks, is it that obesity is a risk factor for fibroid, or obesity and fibroid have common etiological factors that the two are seen commonly together? So this is Dr. Olutosin's question. So any of the clinicians want to answer this question. And welcome to, I see Dr. Cynthia Morton, so welcome to Dr. Morton. So any of the clinicians?
Good morning on a sad morning.
Good morning. See, any of the clinicians want to, or maybe you're ruminating on Dr. Olutosin's question about obesity as a risk factor for fibroid, or the two together. Okay, I see Dr. Chente. Go ahead, Dr. Chente.
Yes, usually they saying obesity can increase the risk of development of uterine fibroid, because we all know that when people are obese, the adrenal hormone can be transformed to estrogen in the fat, increasing the relative proportion of estrogen in the body. So, and that when you have a lot of estrogen, it may increase the development of the fibroid. So it's true that I don't really know whether they will induce the development of the fibroid or they will just contribute to the rapid growth of the fibroid that have started to develop. But I think there's a link that the obesity through the hyperestrogenic state of the obese woman due to the transformation of androgen in the fat to the estrogen is a real, it's a risk factor of the development of fibroids.
Okay. Thank you, Dr. Chente. Let's see, I'm looking in the chat if anyone has put any other questions in the chat. And let me go back to make sure. Oh, is that Dr. Yang?
Oh, no, I'm driving right now, so I don't have any command.
Okay, no problem. Okay, so I'll just move it in. Okay. I'm looking here. I don't see any other comments in the chat, and I know Dr. DeMay or Dr. Dem and Dr. Say they're no longer on the webinar. I don't see. Let's see. Oh, Dr. McConey. Go ahead, Dr. McConey.
Hello there. I just want to take you back in history. Some of you will be old enough to remember the nutritional problems of yesteryear of kwashiorkor and marasmus and underweight and so on. Things that we don't see these days. And that's one point. The other point is that there is a male perception in sub-Saharan Africa that the good woman is the big woman, the heavily built woman. And this is a very, very strong perception, which obviously feeds itself into the female psyche in certain situations. If you want to be loved, if you want to be married, then you must conform to that male standard. There have been comments about obesity, and I just want to say one thing in the light of what I've said about kwashiorkor and marasmus and the heavy woman, that we must start to see obesity as a form of malnutrition, malnutrition of affluence. Thank you.
Wow, yeah, that's a very interesting observation. So I know actually obesity is becoming a problem actually in Kenya, as you know, Western culture spreads, because you know the Western diet. I know Dr. Igbo and a lot of you that came from Africa here, you know that our diet and our cultures can influence other nations. So as you can even see in China, you know, they're taking on some of the bad habits of our diet. So yeah, obesity is becoming a problem in nations where, you know, in Africa, where maybe it was focused on communicable diseases. So now there's a focus on non-communicable diseases like cardiovascular issues, given the diet influences and the shunning of those traditional diets that had the green vegetables or, you know, those indigenous foods that were much healthier. I'm looking to see if there's any other questions that we may have missed. I actually had a question, and this one is actually for Dr. O'Handy, because I saw at Dr. Dem's presentation, they discussed the HM, I think she said it's the HMGA2, the HMGA2 gene. And I believe actually our team has done research on that. I don't know if Dr. O'Handy is able to comment on that, or I know Dr. Yang was driving.
Yeah, no, I really enjoyed that presentation from Cameroon, I believe.
Benin
no,
and Senegal.
Senegal, sorry, Senegal, I'm sorry.
Yeah.
Yeah, this is an amazing international gathering. Sorry if I'm hyperventilating a little bit, I'm exercising. All this talk about obesity motivated me. Yeah, no, that was very interesting. And I actually put a question to her
yes,
on the chat about MET12. So the two most common mutations so far connected to fibroid globally is the MET12 and then the HMGA1. It seemed like they focus on the HMGA1. In the US, MET12 is definitely the predominant mutation in the sporadic fibroid, the general fibroid, not the familial one. You know, the rare cases when you see, you know, the FH mutation and so on. So the range is probably 60 up to 85%. Let's say you take 100 sporadic fibroid samples, you probably will find 60 to 85 of those have the MET12 mutation, and then probably another 10% the HMG1, and then 5 no mutation. So I guess we don't know, probably new mutation will be discovered. But so I asked her about Africa, but she said, unfortunately, there's no statistics. I recall only one paper from South Africa many years ago, and they found about 50% was MET12. But it would be interesting to look at more African studies looking at the MET12 mutation. But it seems, at least at the moment, HMG is kind of number 2, but it's way like far number 2. By far, MET12 is the most common mutation, as far as we know now. We need more studies from Africa. Thank you.
And that's actually an excellent segue, Dr. O'Handy, into my research project. So as you probably have guessed, so I'm also a fibroid survivor. But of course, you know, the literature shows that they've decided to rear their ugly head again. So mine are reared their ugly head again. But as a member of Dr. O'Handy's research team, we have some funding. I have a diversity supplement in which we need African specimens, African myometrium, African fibroids, and even, you know, the normal myometrium. So that way we can look at these transcriptomic factors to compare them to African Americans, because we all assume that, okay, or there may not be any differences between those admixed African American uterine fibroid specimens versus those that are coming from your specific African nation. So there may be something there that could be beneficial to answer these questions, you know, that Dr. Deme, that Dr. Prosper, that all of you are asking, you know, what is the origin? You know, why are women of African descent having these fibroids more? What is the origin, and what is there, you know, even at that molecular, genetic, and that transcriptomic level that can explain or answer some of these questions?
Absolutely, and a little kind of promotion for my presentation. I'm going to talk, actually, we might even have DNA from mummies, from Egyptian mummies 5,000 years ago, and maybe we can go that far. But I really want to take advantage of Dr. Martin, Dr. Cynthia Martin. She's the expert on cytogenetics and fibroid. And if she's still on, if she can comment if there's any data from Africa on that.
Yeah, see her there. Yes, there she goes. Okay, go ahead, Dr. Morton.
Hi. So, you know, I would comment on HMGA2, not HMGA1. I think, you know, a number of years ago, it turns out there's a TC repeat in the 5' region, untranslated region of HMGA2, which has a variable number of repeats. And what was reported about this TC repeat area is that it was not very polymorphic in self-reported Black women out of a study that was run out of McGee Hospital in Pittsburgh. But there was a very different spectrum of repeat numbers in white women. And we looked actually to see if there was an association between that and the fact that HMGA2 in our studies has not been found, the 12-14 translocation has not been found in, at any frequency, basically in self-reported Black women. So we wondered whether that variant actually might influence the prevalence of the translocation. So HMGA1 is much less frequently observed in rearrangements with chromosome 6, was also rearranged in pulmonary chondroid hamartomas and in lipomas. So it's different. I don't know why, because they're both architectural DNA factors, but there's just basically this observation that there's a difference between the prevalence. And in fact, that was the first gene. HMGA2 was the first gene we identified, HMGA2, to be involved in uterine fibroids. There's an answer to all of these empiric observations, but we just don't know what it is exactly.
Right. It's out there. Thanks. Back to you, Lillian.
Yes, thank you, Dr. Morton. So I see Dr. McConey, maybe is your hand still raised from your prior question, or do you have another question? I think it might be raised from his last question. Yeah, I think it's raised. Dr. Igboeli, did you have a comment or a question?
No.
Okay, no.
I'm quite confident. I'm very happy with what is going on here.
Yes.
Very happy.
Yes.
The academic exercise, I love it.
Okay, I'm monitoring the chat and I'm looking at the other questions. I don't see any other questions here.
Well, I just want to make a comment. Actually, I developed a fibroid atlas on the website. But what I'm trying to think, we all are going to be telling us, I saw a lot of fibroids that are presented here. There are multiple. Is it possible that African-based fibroids more or less are multiple, more than the fibroids in the Western Hemisphere? Because if you look at the numbers, sometimes I get more than 100 fibroids in a woman. And really the stimulus, we talked about extracellular metrics from Lisa's presentation, the colloidal scenario. We look at whether it's a estrogen receptor driven, whether it's stem cell driven, whether it is estrogen receptor inculcated into progesterone receptor, into the formation of the extracellular matrix, leading to fibroid formation. We don't know. And I really think that studying also different locations, different sizes, within the same myometrium containing the same, these multiple fibers, will give us a little bit of sense of what is going on here. Because you can see a big fibroid, then see the next fibroid is very little. And I kept asking myself, are the stimulus the same? Are they simulated at the same time frame longitudinally? Or are there any inherent genetic factors that may mitigate one fibroid growing bigger than the other in the same myometrium. If somebody has something to say about that, I would like to know.
Let's see, I saw Phyllis, she was commenting yes, there she goes. Okay, go ahead, Phyllis.
Okay. Many years ago, Donna Baird's group and some people who are no longer working in the field, unfortunately, but they did study, they divided the patients between Black women in America, which is not necessarily pure African, and then white women. And they did find genetic changes. And I had some discussion with my colleague, Jim Seegers, and although this is unpublished, but there seems to be some difference in that's both genetic and also in the amount of collagen that's produced and the growth rates. We don't know a lot about it, but your question is very important. And we also know that there's some differences in, like, some women tend to have just one very large fibroid, and that tends to be more Caucasian women, but we don't know exactly. And, you know, the studies out of America are small studies, and we really need studies all over the world and to do that. But I think your question and your comments are very much on point, because there's so much we really don't know. And then don't forget that each fibroid itself is very different from the other fibroids. And that's something that makes it difficult for us to really study the fibroids. And then another point I want to make is that, and this is a critical thing, when we get fibroid tissue, it's one point at time. It's the time we get it at surgery. But we really don't know what has happened in women prior. I liked your comment so much about how we really need to focus on, you know, this primary prevention and primary treatment of young women. And that's what we really need to work on. And we need to take all these different factors and kind of put them together and see what really is going on. But we have so much more work to do.
Thank you, Phyllis.
That's excellent, excellent point. So to segue from Phyllis's point about the detection, early detection. So I saw in Dr. Fofi's, and actually all of your presentations, where you indicated the need for early intervention, early detection. And so my thought for all of you, and any of you can answer, is what would that program actually look like? Would you want to develop a global, fibroid community health worker workforce that maybe functions different in your individual nations? What would that look like? Because you really do need the early intervention. And I saw Amoy, she's gone now, but she said the education starts from when, young girls start menstruating.
Right.
Dr. O'Handy has mentioned, the dream study would be to look at that myometrium in the teenage girl to find out, okay, what is that hit? What happens that starts, that fibroid to form? So my question to you all is, what would that early intervention or that early detection program look like? Or maybe you haven't thought that far, but you know that it is needed.
One thing ought to be actually, and you talked about this a little bit about, is ultrasound.
Yes.
Studies that come out of the United States are doing ultrasounds very early. And if you pointed out that most physicians have that equipment, and you can teach other people who are not physicians, technicians and so forth, to do it and screen people. But there's more that we really need to work on. But the other thing is, I think we need to understand that fibroids are very common. And if it is true that 80% or 70% of women are going to develop them, that is incredible. And that's another factor we have to keep in mind, that maybe a lot of the things, the question about whether obesity is really a risk factor or whether it's associated. I mean, if we have such a common disease, there are all kinds of things that are going to be associated with it. And we have to watch out for that, And so that's another issue that we need to think about. I personally think there's something that's very different about the uterine muscle that predisposes women to get these things. And don't forget the study that was done in Rochester, New York by a community pathologist who looked at every hysterectomy specimen that came his way over a period of time. And even women who didn't have the diagnosis of fibroids, when they had their surgery, they had fibroids. So it is a real problem, and you know how we solve it is we have to work together on it. But I like the idea of being able to collaborate more with people in your continent, and that I welcome a lot.
Okay, so I see hands raised. So I saw Dr. Morton, and then we'll go to Dr. Alhani.
One thing I was thinking about when you're talking about, you know, targeting for early detection or early prevalence of fibroids is that in the, we published the largest genome-wide association study in uterine fibroids a couple years ago. And in addition to that, we looked at data out of the Nurses' Health Study for prevalence of endometriosis, and found that actually if you had endometriosis, you were at an increased risk for developing uterine fibroids. So I think that if you, and because endometriosis is usually diagnosed at an earlier age than fibroids, maybe a group to watch would be looking for this in young women who have endometriosis. And another thing, just relating back to the fibroids having sort of, you know, distinct growth or location or genetic abnormalities. So we showed that if you want to go and pick up a fibroid out of the pathology lab to culture, and you want to get a 12-14 translocation, then pick the biggest fibroid, because that's likely to have a 12-14 translocation. I think that dysregulating HMGA2 actually, you know, enhances the growth. Whereas if you're looking for a deletion 7, those fibroids don't grow well. They don't grow well in tissue culture. They don't go well in vivo either. So the smaller ones are likely, you know, to have a deletion 7 even more frequently than ones that don't have a karyotypic abnormality. So there definitely are ways you can characterize the individual tumors.
Thank you, Dr. Morton. So Dr. Alhani.
Right. So yeah, these are excellent comments, Lillian. So two quick responses. One, about how would that study, the kind of secondary prevention study, look like? I think Dr. Igupoli already described it. Go to young women, diagnose fibroid by physical exam, if no ultrasound is available, ideally with ultrasound, and then intervene versus, you know, no intervention arm, and follow them for 10 years or so. So yeah, it shouldn't be expensive, and the intervention should be something cheap and inexpensive, safe, maybe vitamin D or whatever the team decide to use. Tomorrow will be a couple of talks about a specific extract from green tea, but it should be natural, inexpensive, and non-invasive, of course.
Right.
But I really want to comment on your call about a global effort. So there is actually a FIGO/WHO international group for abnormal uterine bleeding. It's kind of associated with SUD, Society of Endometriosis and Uterine Disorders. It's led by Hilary Critchley from Edinburgh, from England, or United Kingdom, I should say. She's from Scotland. I need to be careful, right? And Mac Monroe from the US. there's actually no African representation of that, and they kind of took comfort that I'm originally from Egypt, but I'm not really. We need somebody from those wonderful people on the call here who is on the field, on the ground, helping and taking care of these wonderful African patient every day. But there isn't such a person. And it's anyway, it's abnormal uterine bleeding. It's kind of more diluted. Of course, fibroid is there, but it's not the main focus. I would really like to call for a similar group, a global group focusing on fibroid. And maybe this conference could be, you know, the seed for that. And I also encourage Liz and Lillian that we also end up with specific statements, conclusions, highlights from this conference and publish it. There are many possible outlets. We have a journal, Reproductive Science. We're happy to consider this for publication. The paper that Dr. Egoboli referred to earlier, we actually called it Call to Action. That was the title, Call to Action about Africa and Sub-Saharan. So we need more effort on that. And I think this group here in this conference could be the kind of the nucleus, the spearhead for that.
Mm-hmm. Do you think we could get Fogarty at NIH to be interested in some kind of global network?
I would think so, Phyllis. I mean, they are international oriented. This is a huge public health challenge in Africa. I wouldn't say, I don't know why they shouldn't. Yeah, absolutely.
Okay, that's great. So I see that, I think Dr. McConey, his hand is just still raised from before. Okay, I see Dr. Morton. Go ahead, Dr. Morton.
So another possibility that I've made some sort of initial inquiries about is Melinda Gates, because she and her husband, as you know, have gone separate ways, and she's directing some of her donations more into potentially global health problems like uterine fibroids. So I've had a conversation with a friend of mine who's a clinical geneticist who actually works at the Gates Foundation now, and he was saying it would be interesting to see if this is something that she might take up.
I hope so, because we need funding.
Yes. Mm-hmm. Yes. Yes.
Yeah, that would be great, Cynthia. And I know, unfortunately, I don't see Candice Tingen here from the NIH, but Candice also indicated that they have contacted the Gates Foundation, contacted the NIH asking about this topic, and you know who they can, like, where they can get more information. So it seemed that there are interests. So that would be great if we can kind of gear and support that, because yeah, definitely we need the financial support.
Yes. Yes, and I see Mama. Okay, so Mama, would you like to comment on that?
Oh, yes, of course. I'm sorry, I had some problem for the connection, so I couldn't participate as I wanted to the conversation, but I completely agree. There are a lot of work to do, and to do that we need grants. Yes, that's it. So nice to meet you all.
Yes, thank you. Thank you.
Thanks.
I see Dr. Islam here. So Dr. Islam, welcome, Dr. Islam. Did you have any, I know you just joined shortly, short time ago, but did you have any questions? I think he's, he said no.
Thank you so much for introducing me.
Sure. So let's see. So any other questions? I've gone through the chat. I don't see any other questions in the chat. Any other questions before I let Liz from Fibroid Foundation Africa, I can turn it over to her for final remarks for the day. Any last questions or comments?
Moment.
Oh yes, Dr. Fofi, go ahead.
Yes, thank you very much. Yes, in terms of finding interventions, I'm thinking about probably public health interventions that can target a greater amount of people in Africa. And the vitamin D appears to be something that might work, or any of similar interventions that we can target bigger groups. Because if you take our country, Ghana, for instance, the health system is already overburdened. We are unable to have intervention for all the people that have uterine fibroid. So it's good that, yes, focusing on education is paramount. However, all the pathways will direct them to the hospitals that are already choked.
Yes.
So until we improve or expand our arsenal for treatment and find viable ways of proving to the people that there's an alternative in the hospitals, the prayer camps will continue to be in business. The herbal medicines will be in business. If, as we speak now from Egypt, I mean, we had quite a number of interventions that were being performed. That is, the able to use focused ultrasound, the able to use ablation. These are quite a number of interventions that are global. But when it comes to Ghana, these are not accessible to the ordinary Ghanaian. So I think the first step is to be able to put ourselves in an environment where the average is accessible to quite a number of interventions that are standard and available. Then we explore interventions for prevention like supplementation or any nature that will continue to reduce the caseload or the burden. That way it's possible we might be making headway. Other than that, you educate and the people come and they come and spend 3 years in a queue in a hospital, the problem is still where it is. So these are my thoughts on that. Thank you.
Yes. Thank you, Dr. Fofi. That's actually an excellent segue because we want to do a vitamin D multi-site study in Africa. We want to do, you know, an EGCG, you know, study in Africa, you know, because these are proven non-surgical remedies for uterine fibroids. And actually the Ohandi team is involved in a study called FRIEND. Actually, we're in pre-FRIEND. So, but I won't take Dr. Ohandi's, because I'm sure he may talk about this tomorrow since he's presenting. So I will let him speak more on that tomorrow. Yeah, so any other comments? See any other comments? No, I don't see any. So I will turn this over to Liz Corasari from Fibroid Foundation Africa to have final remarks for the day.
Okay, thank you very much, Lillian. This afternoon, I'm so overwhelmed, and I would say thank you very much to all of you who make time to be here with us today, the first day of our premier virtual conference, African Conference on Uterine Fibroids. It's been a wonderful session. So many things have come to light, and I believe it is a stepping stone for us to do greater things. We have heard it all from the experts. Fibroid is very common in Africa. Fibroid is not studied, and it's also, there's also very poor data on it. We've also known that a little effort from us, from the clinicians, from the health officials will make a difference, a significant difference in the life of the women we see each day. So from here, I think we should come, just as Dr. Al-Handi has said, we should come together as for a global initiative, present a document or put together a document for publication so that at least this gathering will be seen or heard by many who were not able to participate. Tomorrow is our day 2. We'll be hearing from Cameroon, we'll be hearing from Tanzania, we'll hear some voices from the United States. I'm trusting that you made time to join us tomorrow for the day 2. Before we leave, I will say sorry for the initial glitches we had with our Zoom connection. And I trust tomorrow it will not happen like that. And the day is still young, so I'm praying that we'll share the link, and tomorrow we'll have many people joining us to be part of this wonderful discussion in aid and in support of the women of Africa and the world beyond. Thank you very much.